can start the program.
Yes, ma'am.
Dr. Hemant Bhatt has not joined up.
I'm still trying to give him a call, ma'am. He isn't picking up.
Hmm.
So we are live now.
Yeah. Start sharing the screen with the first slide. Don't need to listen. A very warm welcome to all the esteemed faculty members and delegates to the Happy Learning Masterclass webinar series by none other than Dr. MC Patel, sir. This webinar is a 204th episode on the specific theme of birth injuries in association with Vapi, Valsad, Surat, Navsari, Bharuch, and Sogok societies. It is heartwarming to see that every episode has more than 300 delegates online attending, realizing the themes and the topics chosen, and the faculties who give a lot of time and dedication to the talks. Hats off to you, Patel sir, for designing the course and keeping the academic content very, very crisp. So let us take blessings of Lord Almighty and we can start the webinar. So can we have the inauguration slide? Thank you, Mr. Nilesh. It is my proud privilege to introduce the master of this series, Dr. MC Patel, sir. Sir is a consultant obstetrician, gynecologist, and a medical legal counselor. Sir has been the president of Ahmedabad Obgyn Society, the IMA Ahmedabad, the national president of NMO in 16 to 18. He has also been the organizing chairperson of Vivekanand NMO conference in 2013. He is an honorary surgeon at the Red Cross Eye Bank. He also holds services in the medical camp in the Northeast states and the Dhanvantri Seva Yatra of MO and Seva Bharati, which is organized in the last 23 years. Sir has been ever helping to all the Foxians, whoever is in trouble for medical legal complaints. The only name that people remember is Dr. MC Patel, sir. Sir has been the vice president of Foxy in 2018. And sir, I welcome you to welcome the August gathering and also welcome our esteemed faculty members, Dr. Rosie Oya ma'am, who will be speaking on obstetric injuries. Dr. Ashwin Vachani sir will be speaking on scar dehiscence, and Patel sir will be speaking on legal issues in obstetric injuries.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all on 204th episode of Happy Learning Masterclass web series. And today it is with Sogok and 5 societies of Sogok from South Gujarat, Vapi, Valsad, Surat, Navsari, and Bharuch. I welcome Dr. Atul Munshi sir, who has kindly consented to be chief guest to bless us. I am lucky enough, he is always with me to bless me in any of my academic or other activity. So welcome Atul sir. I also welcome Dr. Hemant Bhatt, Joint Secretary of Sogok, and Dr. Jignesh Deliwala, Treasurer of Sogok. They both are working with me in Sogok since long. So welcome both of you. I also welcome all the learned faculties, Dr. Akash Gajjar, Dr. Deepika Singhvi, Dr. Sailja Maskar, Dr. Roji Madam, Dr. Khyati, Dr. Phalguni Thakkar, Dr. Ruta Vekaria, Dr. Ashwin Vachani, Dr. Percy Kharas, Dr. Vipul Kapadia, Dr. Jayshree Jena Kapadia, Dr. Narendra Gajjar, Dr. Chintan Thakkar, who is president of SOGOG also, working with me in SOGOG and guiding us throughout the year as far as SOGOG activities are concerned. And two experts will be there in panel, Dr. Praful Doshi and Dr. Pawan Dheer. And all the learned panelists, Dr. Vaibhav Kapadia, Dr. Kokila Desai, Dr. Kuresha Qureshi, Dr. Darshan Wadekar, Dr. Hiral Pandya, Dr. Sital Talekar, Dr. Aditi Narkarni, and Dr. Vaibhav Narkarni and Sarfaraj Kaji. And of course, my team, Dr. Monica Umurdan, convener from Solapur, and all the coordinators, Dr. Monica Gupta from Alwar, Dr. Nivedita Datta from Bokaro, Dr. Satabdi from Siliguri, Dr. Deepika Logani from Delhi, and Dr. Megha from Kalaburgi. And I welcome all the delegates who have joined this webinar. And we have selected this topic, birth injury or obstetric injury, whichever we call. It is a common entity in our day-to-day obstetric practice, and we may end up into this kind of injury. And how to deal with? First part is how to prevent it, and if at all it happened, then how to diagnose, how to deal with is the motto of this. And ultimate goal is to check maternal and infant morbidity, and in few of the cases mortality also, because as an obstetrician we are primary concern to check maternal mortality, which is prime concern for us, because by 2030 government and WHO has given us a target, it should be less than 70. Of course, India is doing good and Gujarat is doing good as far as this MMR is concerned, but still long way to go, because there are few states where still maternal mortality rate is near 200, and it's a matter of worry, matter of concern directly as an obstetrician. So considering all this, we are discussing this type of cases every Tuesday in this series, and to update our obstetrician friends from Foxy to deal with the situation accordingly. So welcoming you all. Thank you very much.
Sir, I also request you to introduce our chief guest, Dr. Atul Munshi, sir.
So Dr. Atul Munshi, just I mentioned, our good supporter always in any kind of our activity. He is consulting obstetrician and gynecologist, director at Munshi Group of Hospital, Ahmedabad, former professor and HOD at GCS and NHL Municipal Medical College, Ahmedabad, editor-in-chief, Journal of Midnight Health, president IMS 2010, IMS representative to APMF 2021 to 22, IMS representative to CAMS 2017 to 18. Foxy
sufficient.
Yes, sir.
It's okay.
But yes, sir.
Thank you.
But overall, you are always there with us to guide us in any situation. So welcome, sir, and you are here to bless us for the same. Yes, thank you, sir. Welcome.
Thank you, Dr. M.C. Patel, for involving me in this elaborate number of academic event. Obstetric is my favorite subject from very beginning. Today, I am fortunate to be amongst stalwarts of Gujarat discussing important topic of birth injuries, a nightmare for any obstetrician. I see names of Dr. Percy, Dr. Vipul Kapadia, Dr. Hemant Bhatt, Dr. Jignesh Deliwala, Dr. Rosie, Dr. Ashwin Vachani, Dr. Narendra Gajjar, my good friend, Dr. Chintan Thakur, and above all, Dr. Praful Doshi and Pawan Dheer in this list of today's webinar. Good evening, everyone. Obstetric injuries, as you rightly said, though largely preventable, remains a significant contributor to maternal morbidity and compromised quality of life. A multidisciplinary approach involving obstetrician, urologists, physiotherapists, and mental health profession is essential for effective management. Prevention, though improved, is possible, though improved obstetrics care, timely intervention, and skill delivery remains the cornerstone of reducing such injuries. Today, learned speaker and equally expert chairpersons will throw light on special aspects of perineal tears and wound dehiscence. Dr. Narendra Gajjar and Dr. Chintan will cover other aspects of birth injuries in an interesting panel with skilled panelists. Our medical legal expert and candidate for highest post of FOXI, my good friend, for 2026, Dr. MC Patel, in his unique style, will clarify the possible legal consequences and remedy for unwanted injuries. I'm sure at the end of today's webinar, we all will leave with renewed idea about birth injuries and methods to tackle. Congratulations for such a long series, and thank you for involving me once again. And best of luck for your future endeavor.
Thank you, sir, for sparing time to bless us for this webinar. And over to you, Monica, for further proceeding.
Thank you, sir. Thank you so much for your blessings. It is a privilege to share the stage with you. I would now request Dr. Monica Gupta, madam, from Alwar, to introduce our guest of honor, Dr. Hemant Bhatt, sir, and Dr. Jignesh, sir. Monica, ma'am, please start introducing Jignesh, sir. Hemant Bhatt, sir, was actually on the delegate side. I have give him the new link. He is joining in some time.
Good evening, everyone. Thank you, MC Patel, sir, and Dr. Monica for giving me opportunity. It is my proud privilege to introduce guest of honor, Dr. Jignesh Deniwala, sir. He's a consultant gynecologist at Geeta Maternity and Nursing Home, Ahmedabad. He's an Ian Donald Diploma in OBGY sonography, trained at Mediscan for fetal echo and color Doppler in obstetrics. His special interest is in high-risk pregnancy and infertility, trained for FOXI recognized basic laparoscopy and hysteroscopy at Kodawala Hospital at Ahmedabad, and he's a past president of Ahmedabad OBGY Society and joint secretary of AICOG 70. Over to you, sir, for your blessings.
Thank you, ma'am, for a kind introduction. I would like to congratulate Dr. MC Patel, sir, for organizing this webinar. And it was, I think, previous 203 webinar has excellent success over the period of time. And I would congratulate him and also wishing him a best luck for future election for the post of FOXI president. And I welcome all the delegates, all the faculties on today's webinar on obstetrics birth injuries. Thank you, sir, for inviting me for this webinar. And I would like to best wishes to all the esteemed faculties, senior friends, and colleagues for a successful this program. Thank you. Thank you, sir.
Thank you, Dr. Jignesh Deniwala, for kind words. And over to you, Monica.
Monica, ma'am, you introduce Hemant, sir. I'll just see if he's joined back.
I don't see he has joined. I'll just introduce him.
Introduce, yeah. In the meantime, I'll call him.
It's a proud privilege to have Dr. Hemant Bhatt, sir, as a guest of honor. He's MD LLB. He was the president AOGS from 17 to 18, joint convener SOGOG from 22 to 24, and organizing secretary of AICOG 2017. Over to you, sir, for your blessings. We knew that Ahmedabad conference was a great success, and we have two men who are behind this conference in our webinar. We are very proud to have them with us.
Yes, Dr. Hemant.
Good evening, Dr. MC
Yes,
Patel.
welcome, welcome.
And good evening, ma'am, for a nice introduction. Actually, I just joined within 2 or 3 seconds, and my apology for all of the faculties and also the delegates who have joined this Zoom meeting. But it is always a very pleasurable experience whenever Dr. MC Patel is there and when he is conducting this mixed bag of all the academic programs through these happy learning webinars. And I learned that this is the 204th episode of our webinar. So in the near future, we will be completing more than 4 years. That is a kind of a stupendous achievement, I must say, that you have continued. And as far as our obstetric practice is concerned, when we are discussing today the birth injuries, that if we want to avoid the real life PPH, that is the personal petrified hazardous kind of a life, then you should practice the PPH of MC Patel. That is patience, perseverance, and a humility. The way he conducts himself all the time, wherever we are meeting in person or this kind of a Zoom meeting, we always find something to learn. And I am also very, very happy in a way that our SOGO member societies like Bharuch, Surat, Navsari, Valsad, and Vapi, and all the respected dignitaries of the societies are joining in this webinar. And we are going to have a wonderful next 1 to 1.5 hours to update our knowledge regarding the obstetrics. And I wish the webinar very, very well. And I wish Dr. MC Patel for a wonderful, glorious victory ahead as a Foxy president in the coming election for the Foxy. Thank you, sir.
Thank you, Aman bhai, for kind words and all the blessings. So over to you, Monica, without wasting much of our time, to straightway to academic session.
Thank you, Munshi sir. Thank you, Hemant sir. And thank you, Jignesh sir, for gracing the occasion. I now declare that the inauguration is over. And sir, thank you. I will definitely use all the 3 words in next time when I introduce Patel sir for every webinar. So I now hand over the session to Dr. Deepika madam to conduct the first session. Ma'am, please unmute yourself.
So greetings from Delhi, and thank you, Dr. Patel sir and Dr. Monica, for making me a participant and coordinator in sir's webinars, future webinars. And I would like to start with the academic session, which is the first session of the day, to start by introducing the chairpersons for the first session. Please, could I have the slides, please? Yeah, so the first session, I would like to introduce the chairpersons for the first session, Dr. Akash Gajar. Actually, this is very, I'm very sorry. Can you just make this slightly larger? Sir is the secretary of Dr. Monica. Actually, this is very, very small.
Ma'am, I'll introduce him.
Yeah, please.
Sir is working as a fertility consultant and an endoscopic surgeon. The embryologist is at Akash IVF Center and Ashirwad Hospital, Chittal, and Akash IVF Center at Navsari. He is also the assistant professor at Vedanta Institute of Medical Sciences, Dhanu. We welcome you, sir, as a chairperson for the first session.
Yeah.
Good evening, everyone.
Can we go on to the next? Can I introduce the next chairperson? So our next chairperson for the first session is Dr. Deepika Singhvi. Madam is MS Obs and Gynae, and she's a consultant at Avia Women's Hospital at Vapi. Ma'am is the secretary of Vapi Obs and Gynae Society, and she has postgraduated from Government Medical College, Surat, and has a fellowship in fetal medicine from Paras Fetal Medical Medicine Center at Ahmedabad and BFMC Bangalore. Welcome, ma'am, to the session. Can we have the slide for our, yeah. So, good evening, ma'am. We welcome Dr. Shailaja Bhaskar, ma'am, as our chairperson for the first session. Ma'am has passed her MD and DGO long time back from Medical College, Surat, and she's a practicing obstetrician gynecologist at Bhaskar General Hospital, Valsad. And ma'am is also the past president of Valsad Obs and Gynae Society. from the year 2023-24. She was the past president of WAPI Obs and Gynae Society in the year 2011 to 2012. Ma'am has got many awards and papers and research, has many publications. Welcome, ma'am, to the session. And can I request our chairpersons to introduce our esteemed speaker and start with the academic session, please? Could we
Yeah,
have the session, the slide for Dr. Rosie Ahalia, ma'am?
Akash, you will introduce.
yeah. Good evening, everyone. Thank you, Dr. MC Patel, sir, for this wonderful opportunity. And it's a privilege to introduce Dr. Rosie. She has passed her MS from Dheeraj Hospital, Waghodia, and she has been working as a consultant obstetrician and gynecologist at a Kiran Multi-Speciality Hospital since last 8.5 years. She is a pioneer in robotics gynec surgery in South Gujarat, and she has a fellowship in minimal access surgery under the guidance of Dr. R.K. Misra, and she has infertility training from Dr. Kamini Rao. She has been awarded the best paper presentation in International Congress in Mumbai in 2012. And she is currently the secretary of SOGOG in 2019 and 20, and she was organizing secretary of FOXI Presidential Conference in 2024. Over to you, Dr. Rosie. She will be speaking on obstetric anal sphincter injury.
Yes. Thank you, sir, for the kind words. At the outset, I'd like to thank MC Patel, sir, for giving me this opportunity to be here in front of all of y'all. It is a great pleasure to be a part of this webinar. I'll start with my screen share. You can see my slides?
Yes, ma'am.
Yes, it is seen.
Okay. So today I'll be talking about obstetric anal sphincter injuries, what we call as OSS. So defining OSS basically refers to the 3rd and 4th degree perineal tears. As we all know, there are 4 degrees of perineal tears. OSS includes only the 3rd and the 4th degree. 3rd degree is when it involves the anal sphincter complex, and 4th degree is when it extends through the anorectal mucosa. So first, before we start, we should know our anatomy. Certain basic muscles we have to know from where to where it goes. What are the muscles, where they are localized. So if you go to see, this is the bulbospongiosus muscle, which goes from behind the pubic symphysis to the perineal body. Then on the lateral side, we have the ischiocavernosus muscle. Here we have the superficial transverse perineal muscle. Here is the perineal body. This is the external anal sphincter. And here we have the levator ani. So this is basically forming the entire perineum of a lady. Coming to the internal and external anal sphincter. The internal anal sphincter, it consists of the circular muscle fibers of the rectum, which are continued downwards. And it is white in color. So it is basically resembled and said it is to be like that of a white meat, like we can say of fish or chicken meat. While as the external anal sphincter, it is consists of striated muscles and it is red in color. So it is compared with red meat. So here we have the anus, around is the internal anal sphincter, white in color, and surrounding is the external anal sphincter, which is red in color. So incidence of OSS, it is basically 0.25 to 6%. 53 to 79% of the patients have lacerations during vaginal delivery, but only 3.3% have 3rd degree, while as only 1.1% have 4th degree, which forms OSS. Why is this so important? Because it leads to anal incontinence later in life. This is what is really troublesome for the woman. That is why it is important for us to know how to prevent and treat OSS. So what are the risk factors? Everybody does not have OSS. So what are the risk factors? In which cases there are chances that the lady will have OSS? Macrosomy, where the baby weight is more than 4 kgs and we go for a normal vaginal delivery. Instrumental deliveries, mainly forceps delivery. Prolonged 2nd stage of labor. Then there are others like a midline episiotomy, induction of labor, epidural analgesia, occipito-posterior position, shoulder dystocia, nulliparity, advanced maternal age, or Asian ethnicity. So we should know, okay, these are the risk factors. So we can know, okay, in which cases we have to suspect or try to prevent OSS. So perineal laceration, as we all know, first degree is where there is injury only to the perineal skin, while a second degree when it also involves the perineal muscles. Coming to the third degree, it is involving the anal sphincter complex. This is further divided depending upon what is the depth of the injury. It is 3A is when it is injury is less than 50% of the external anal sphincter. 3B when his injury is more than 50% of the external anal sphincter. And 3C when there is full thickness injury to the external anal sphincter and involvement of the internal anal sphincter. Fourth degree is when there is all of the above. That means including 3C plus includes the anorectal epithelium. There is something what is called as occult ASS. We should be aware of this terminology. It is not identified at the time of delivery or there are no clinical findings, but it may be recognized at a later stage by endoanal ultrasound. 27% of women tend to have occult ASS after their first vaginal delivery. Clinical training and experience can improve the detection rates. Thus, we have to consider digital rectal examination at the time of delivery to be able to identify these cases. And an experienced provider is generally needed for such cases. How do we diagnose OSS? Careful perineal and rectal examination should be a must after every vaginal delivery. Use adequate lighting and analgesia when you're examining the patient. And if we suspect OSS, we have to make sure we have some clinician who's senior to us, who's more experienced, available with us. RCOG recommends to do an endoanal ultrasound, though this is not recommended by all other guidelines. But as per the RCOG guidelines, we should do an endoanal ultrasound in all cases. So this is how an ultrasound looks. If we go in detail, this is the epithelium. This will be the subepithelial tissue around. Around that, we have the internal anal sphincter, and then we have the external anal sphincter. This is how it looks on ultrasound. If we go by a longitudinal view, this will be the internal anal sphincter. Then we have the external anal sphincter, and surrounding it is the levator ani muscle. Now we know the patient has OSS. We have to repair it. So what is the timing of repair? As per most of the guidelines, they say that the repair should be immediate. But certain guidelines say that you can repair even after up to 8 to 12 hours later. We have to make sure that we give adequate regional or general anesthesia during repair. A Foley's catheter has to be inserted and it should be placed for 12 to 24 hours to avoid urinary retention. It is often useful to place a pad high in the vagina so that any uterine bleeding, it does not obscure our surgical site. We have to check the extent of the cuts and the lacerations. And if it is more complex, make sure we have someone experienced along with us. So how do we manage? First degree perineal lacerations, repair only if there is bleeding or it is distorting the anatomy. Otherwise, they can be left alone. Second degree perineal lacerations, you have to repair them with absorbable synthetic suture with continuous suturing. How do we repair OSS? Always remember, OSS has to be repaired in layers. First is the anal mucosa, followed by the internal anal sphincter, and then the external anal sphincter. Now, there are two techniques of repair. It may be either an end-to-end repair or an overlap repair. In the short term, the studies show that overlap repair is better when it comes to the results. But in the long term, both have similar results. So we can go for either end-to-end or overlap repair. So both are acceptable. Overlap repair is generally associated with lower rates of fecal incontinence. For 3A, we have to go for end-to-end repair. But anything 3B or above, we can go for end-to-end or overlap. Preferably go for overlap repair. Monofilament suture material is recommended by all guidelines. Here, there is no controversy. Whenever we are repairing OSS, we have to make sure we always repair with a monofilament synthetic suture material. The anorectal mucosa is to be repaired with a 4-0 monocryl by running sutures and make sure the knots are external to the anal canal so that it does not irritate the anal mucosa. The internal anal sphincter and external anal sphincter are repaired with a 3-0 PDS by interrupted sutures. Here, no overlap technique is used. The perineal body is sutured by a 2-0 monocryl with interrupted sutures. Vaginal mucosa is by 3-0 monocryl with interrupted sutures, and skin is always by subcuticular sutures as per a Cochrane review. Always make sure we should avoid figure-of-8 sutures when we are repairing OSs. The cut suture should always be made, the suture should always be cut short. Cover the knots by overlying superficial perineal muscles. They should never be left open. So now suppose this is the end-to-end repair. Now what we do is we go from out to in. Here we go from in to out. Again, go from out to in and in to out. So this is how, depending upon the thickness, we may need 2 or 3 sutures. So out to in and in to out, out to in and in to out. This is how we approximate. When it approximates, it appears like this, end-to-end sutures. So this is like what we said, white meat. Internal anal sphincter looks white in color. So when identified, we have to repair it by end-to-end technique. And after that, we repair the external anal sphincter by, again, end-to-end technique. Now, this is the overlap technique. In this, we have to go from out to in, again go from out to in. Here, we go from in to out and again in to out. And then we tie the sutures here. Similarly, according to the thickness, 2 or 3 sutures. So this is how it will look, overlap repair. Before finishing the repair, we have to always make sure we do a per rectal or a per vaginal examination at the end. It is a must. We should check for our swabs, needles, instruments, everything should be checked properly. Beware if there are any sutures in the rectum. So when you do a per rectal examination, see if any sutures are felt there. If so, you have to cut it and remove it. No suture should be felt in the rectum. You have to see if any buttonholes are missed out. Then you have to repair those. And see that you have not missed the apex of the incision site. Coming to antibiotics, large UK-based multi-center double-blinded RCT demonstrated that a single dose of second-generation cephalosporin decreased the infection rate immediately and at 6 weeks postpartum. So after every OSS repair, antibiotics is a must. Some say you can give a second-generation cephalosporin single dose. Some say you can give a single dose of IV 1 gram amoxicillin and 200 milligram of clavulanic acid. RCOG, however, states that you can give broad-spectrum antibiotics. So it is any antibiotic, but it should be a broad-spectrum antibiotic. Coming to now, we've repaired. What is the postpartum care? Laxatives should be given to every woman with OSS for at least 1 to 2 weeks, so that she will not have hard stools and it will not put a strain on a surgical site. Analgesics, because these ladies, they tend to have a lot of pain. So we have to make sure she has adequate painkillers like NSAIDs or paracetamol. Daily care and hygiene should be maintained. Pelvic floor physiotherapy is a must. Pelvic rest, no intercourse for at least 6 weeks should be strictly advised. She should have a follow-up at 1 week and then again at 6 to 12 weeks postpartum. Some guidelines state that we should do at every follow-up an endoanal ultrasound and anal manometry, while some guidelines do not recommend it. So it is a personal choice. If the symptoms still persist, then we have to refer the lady to a colorectal specialist. Follow-up, closely monitor for signs of urinary retention. These ladies, due to a lot of pain, they may go into retention. So we have to make sure she's not going into urinary retention. Short-term close follow-up is required because 25% of patients tend to have a wound breakdown and 20% tend to have infection because of the stool site. Patients with OSS complications and or psychological trauma after OSS may be offered primary cesarean section for subsequent deliveries. So how do we determine the mode of delivery after OSS? So pregnancy, if she is conceiving after OSS, you have to see whether she's symptomatic or asymptomatic. This is further divided whether she's into severe, borderline, or intact. So what do you mean by intact? Intact means there is no external anal sphincter defect and the pressures on an anal manometry are normal. Borderline is when the external anal sphincter defect is more than 1 hour and less than 2 hours. Here by 1 hour, they mean 30 degrees angle. And the anal pressure increment is of 20 to 40 millimeters of mercury. Severe is when the external anal sphincter defect is more than 2 hours, that means more than 60 degrees, and the anal pressure increment is below 20 millimeters of mercury. So if she's symptomatic and severe, cesarean section or vaginal delivery is controversial. If she's symptomatic and borderline, cesarean section. If she's symptomatic and intact, vaginal delivery. If she's asymptomatic and she's severe, cesarean section. Borderline, again, cesarean section may or may not be done. But if it is intact, we can go for a vaginal delivery. So how do we manage OSS? Anal manometry and ultrasound, as we said, it may be controversial, but yes, you can do it. Follow up with these tests. If it is normal and patient is asymptomatic, allow her for a vaginal delivery. If these reports show abnormal, that is defect of more than 1 hour or a pressure of less than 20 millimeters of mercury, or if she's symptomatic, like she has fecal incontinence, and if she's completed family, we go for a repair. If not, we allow her to first deliver and then decide about repair. If she has minor incontinence, like only flatus passing, or she's just staining, then we can go for conservative management with dietary advice, regulate the bowel action, constipating agents, pelvic floor exercises, and biofeedback. And finally, she should be offered a cesarean section. So what are the complications of OSS? Why is it so important that we should not let any woman have OSS? Because it will lead to anal incontinence. It is very discomforting for the woman to have anal incontinence. It will lead to perineal pain and dyspareunia. She's always very uncomfortable with the perineal pain. There are chances that she may have a wound breakdown or infection. And finally, all this leads to a lot of psychological distress. So OSS, we have to see if it is diagnosed, then we can go for a reconstructive surgery with primary repair. Full thickness tears, then go for overlapping. Partial thickness, go for end-to-end repair. You have to see if functionally successful or not. If there's a failure, or if she has, it's not undiagnosed, but she has symptoms, then we may go for conservative management like behavioral and medical therapy and pelvic floor physiotherapy, or we can go for an operative management like sacral nerve modulation, reconstructive surgery, bulky agents, sphincter replacement, stoma, or other methods. So now we know OSS when it happens, how to repair. But ideally, as MC Patel sir said, all these birth injuries should ideally best be prevented. So how do we actually prevent OSS? Let not a woman not have OSS at all. So how do we prevent it? By a controlled delivery of the head, use of warm compresses and perineal support. Avoid a midline episiotomy. If at all episiotomy is needed, always go for a mediolateral episiotomy. Adequate training and supervision of the consultants is important. So there is a safe passage protocol to reduce OSS. So what does it include? SAFE is a full for short form for S, start perineal massage at 36 weeks. A, alleviate fear and anxiety, facilitate occipito-anterior position, eliminate midline episiotomy. Passages, place warm compresses on perineum, though this is slightly controversial because it may lead to scarring. So we have to be careful if we are using warm compresses. A, adduct the thighs at delivery 90 degrees or less. Straighten the legs at delivery 90 degrees or less. Support the perineum hands-on. Aim for a mediolateral episiotomy, that is, never give a midline episiotomy. Go slow, control the head, and deliver after contractions. Excel at operative delivery, as and when needed, we may use it. And superb repair technique is important. So if we have to give episiotomy, then we know there are midline episiotomy, mediolateral episiotomy. So midline episiotomy is within 3 millimeters of the midline and extends 0 to 25 degrees of the sagittal plane. So up to 25 degrees of the sagittal plane, it is called as a midline episiotomy. For medial, it again starts from the fourchette that is within 3 millimeters of the midline and extends laterally towards the ischial tuberosity at an angle of at least 60 degrees. This is important. We have to make sure if you're giving a mediolateral episiotomy, it should be 60 degrees angle with the sagittal plane. If we give at a 40 to 45 degrees on a stretched perineum, it is actually, we are giving it at a 22.5 degrees. So that is not beneficial. So it is good that we give it at a 60 degrees. Prefer restrictive episiotomy versus routine episiotomy in all cases. If at all needed, mediolateral episiotomy. And EpiScissor 60 has been introduced, which will help us to identify this 60 degrees. So this is the EpiScissor 60, wherein we can identify, okay, now this is the sagittal plane. From here, we take an angle of 60 degrees and we make an incision. So what are the indications actually where episiotomy may be given? If there is a delay due to a rigid perineum, if there is a tear, it seems imminent, or if we are going for instrumental delivery, mainly forceps delivery. The OAC Care Bundle is a quality improvement program to reduce the incidence of severe perineal trauma, which is introduced by RCOG. It contains 4 elements, that is antenatal information for the woman, manual perineal protection for vaginal births, episiotomy at 60-degree angle if at all indicated, and perineal examination after vaginal birth to include a perectal checkup. So, concluding, obstetric anal sphincter injuries are comprised of 3rd and 4th degree perineal lacerations with a higher risk of anal incontinence later in life. Rates of OSS are increasing. Episiotomy should not be routinely utilized. They should be reserved for situations based on clinical judgment. Can prevent OSS with the help of OAC Care Bundle. And whenever we are repairing OSS, always make sure we use monofilament sutures. Thank you.
Thank you, ma'am, for a comprehensive review of the topic. And may I request the chairpersons to kindly give their expert comments. Dr. Akash, please.
Yeah.
Dr. Sailja madam is also there.
Yes.
Yeah.
One.
So she can have concluding remark and we can close the session.
Yes.
And
Thank you.
Yes.
Thank you
Yes.
so much, Dr. Rosie, for your total elaborative point-wise causes, management, treatment, everything about the anal birth injury. You did it in a nice way. Thank you so much.
Thank you, ma'am.
Good evening, everyone. And we begin our second session. So I would request the chairpersons of this session to please introduce the speaker. And the first
I
chairperson.
request all others to please mute so that we can hear it clearly.
Okay, and the chairpersons for this very interesting session, Dr. Khyati Daru, the past president of Vapi Obs and Gynae Society, who's been practicing for last 17 years and has received the Young Gynae Achievers Award. She has got immense interest in 3D as well as 4D ultrasound. The next chairperson for this session is Dr. Falguni Thakkar. And Dr. Falguni is now the secretary, Bharuch Obs and Gynae Society. Interest in fetal medicine and ultrasound. She is a certified FMF sonographer with and delivered a number of lectures at national, local, and state conferences. She's also been the past president of Indian Medical Association, Bharuch. The third chairperson of this session is Dr. Ruta Vekaria. She's another fetal medicine specialist, and she has with 1 year in fetal medicine, 1 year in fellowship in fetal medicine. She's worked as a fetal medicine consultant at Ruta IVF Center and now has started her own venture, which is the Ruta Fetal Medicine Centers. She is the secretary, Surat Obs and Gynae Society. With these three very talented, very academic chairpersons, we hope to have a very interesting session as the second session. And I request any one of these chairpersons to please introduce the speaker, Dr. Ashwin. Dr. Falguni, could you please introduce Dr. Ashwin? Please unmute yourself, Dr. Falguni.
Yes, ma'am. A very good evening to one and all. It is a pleasure to be in this webinar. Dr. Ashwin, sir, he's a great academician. Very frequently, we call him to Bharuch and have a number of lectures with him, and it's really fun listening to him. Ashwin, sir, has done MBBS and MD from NP Shah Medical College, Jamnagar. He has done his DNB from New Delhi, and he's a member of the National Academy of Medical Sciences, New Delhi. He is at present the professor and head of the Obs and Gynec department in Swimmer, Surat, president of Obs and Gynec Society, Surat from 2013 to 14, clinician, ethical committees member, secretary, Gymkhana committees member, master trainer of EMOC project run by Foxy GOI. He has a special interest in emergency obstetric care, urogynec, and gynec oncology. He has a number of publications in national and international journals. He is invited as a faculty in various states, national and international conference. But the most important introduction, what I want to give for Ashwin Vachani is that he is a great teacher, and any student who comes and tells us he or she is a student of Ashwin sir, we say, okay, ab koi chinta ki baat nahi hai. Welcome, Ashwin sir.
Thank you, madam.
Thank you, Dr. Falguni, for introducing Dr. Ashwin. And I would request Dr. Ruta Vekaria, if she is there, please introduce the topic which he is going to speak on, because it's a very, very interesting topic and something which is the need of the day to reduce the need of C-sections, repeat C-sections. Dr. Ruta, are you there, or Dr. Khyati? If not, Dr. Ashwin, you can please start. Yeah, the stage is yours.
Thank you for nice introduction. Thank you, Dr. MC Patel, for completing the double century, because the Happy Learning Masterclass web series has completed 203 series, and this is 204th. And I have the proud privilege to become the faculty third time in this series. Now, can you see my slide?
Yes, Dr. Ashwin. Could you make it full screen?
Yeah, done.
Thank you.
Just a minute. Okay. So, topic given to me is scar adhesion in the obstetrics. So, I will divide this topic in two groups. One is for the general aspect of the uterine scar adhesion, and last part is specially for the monitoring of the scar during VBAC. Because if we don't select properly for the VBAC and don't monitor, then it may lead to the scar adhesion and the subsequent compromised fetal-maternal outcome. So, preventive aspect, as Dr. MC Patel has rightly said, is much important. So, I give the special focus on that aspect in the second half of my talk. So, first we see what is scar adhesion. So, uterine scar adhesion refers to the separations of the uterine musculature at the scar site with the uterine seroja still intact. So, it is a defect in the muscular layer and with still the seroja is intact. And incidence, if we look at, then it is 0.2 to 4.3% of the all pregnancy with previous cesarean section. Because this is the study done only for the previous cesarean section, but there are a lot of other surgery now we are doing on the uterus, like the myomectomy, hysteroscopic surgery for the septum and the Esserman syndromes and all these things. They are also the scar on the uterus, and they can also lead to the similar problem like the scar adhesion. But we have the incidence regarding the previous cesarean scar adhesion only. It can occur during the pregnancy, that is antepartum, during the labor, that is intrapartum, or even after the delivery, that is postpartum. And another important aspect is in 48% of the cases, it remains the asymptomatic. So we have to be very vigilant during the ultrasonography to pick up such asymptomatic cases to prevent the rupture during the labor. And it may present with the pain, bleeding, or signs of infection, particularly if it occurs in the postpartum period. If not predicted, it can lead to the uterine rupture and all its consequences. So, what are the risk factors for the development of the scar adhesions? We have already said that most common reason for the scar adhesion is the previous lower segment cesarean section. But all previous cesarean section doesn't have the scar adhesion. So, what are the high risk factor in this particular previous cesarean section? So, it includes the multiple previous cesarean. If the number of cesarean increases 2 cesarean, previous 3 cesarean, then definitely chances of the adhesion is increasing. Some special indication of the cesarean in previous cesarean section, that is obstetric labor, chorioamnionitics, because all this will lead to the poor healing of the scar and weaker scar. Same way, intraoperative hematoma or endomyometritis after the cesarean section can cause the uterine adhesion and also disrupt the scar healing. And type of this incision on uterus, like classical cesarean, inverted T, extension to the upper segment, all this can lead to the weaker scar and more likely to have the adhesion in subsequent pregnancy. And technique or experience of the surgeons may also play the role. And now many a time we listen that the single layer have the more chances of scar adhesion. But dear friends, in published series, there are no clear-cut statistical significance whether you close the single layer or double layer. Theoretically, double layer can give the thicker scar, so which is less likely to rupture. Single layer give the thinner scar, which is more likely to rupture. But if you compare the outcome and published series, then there are no significant difference. So currently we can have the single layer or double layer as per the choice of the surgeon. But most important aspect is the how you close the end to end. So there should be the proper appositions from the upper and lower margins of this uterine wound without protruding of this decidual tissue. That is more important. That's why one small series have compared the closure of the uterus in single layer, whether you close by the continuous unlocking or continuous locking series. But if you lock the continuous locking stitch, then there are more protrusion of the decidia and the weaker scar. So that is also proved in one small series. So these are some aspect of the technical aspect of the closure of the wound that also matters for the scar disease and subsequent pregnancy. Now other causes include the underlying anatomical defect on the uterus, which would have been corrected prior to the pregnancy, like the uterine septum correction, intrauterine adhesion slices, or myomectomy. So that can also lead to the problems in the subsequent pregnancy. There are few other factors like diabetes mellitus, emergency cesarean section, infection at the time of cesarean or after cesarean, preterm delivery, incision placed too low in the lower uterine segment, short inter-delivery interval, particularly less than 18 months in few studies have proved that it is more chances of the scar adhesions. Now you come to the symptoms. As I already told, more than almost 48% of the patients are asymptomatic and can be picked up by ultrasonography only. Other patients may present with the pain, and usually this pain are some patients having a sharp stabbing or burning pain, especially during the pregnancy at the site of the uterine scar. And some patients adhesion occurs at the time of the delivery, and that remain persist, and patient may present with the secondary postpartum hemorrhage, abdominal pain, or puerperal feature suggestive of the puerperal sepsis. Now, how to diagnose? Again, it depends on which time you are trying to diagnose this scar adhesion. So even before pregnancy also, if you do the good ultrasonography, we can pick up the isthmosis and the knees. So that is also, if patients, we allowed such patient to become the pregnant, then during antenatal period, it is present as a scar adhesions, and during labor, stronger contraction may lead to the giveaway and rupture. And same way in antenatal period, again, patient may be asymptomatic, patient may be present with the pain or bleeding. And of course, ultrasonography is the main tools to diagnose. In ultrasonography, lower segment thickness we have to measure. If the scar thickness is more than 2 mm, then it is considered as a good scar. Anytime it is less than 2 mm, then we have to be very vigilant. But only thickness is not the criteria. So other features like significant thinning or disappearance of the muscular layer, or most significant is the protrusion of the sac from this window, that is highly suggestive of the scar adhesions. And sometimes in doubtful cases, we can take the help of the MRI. And this is the pictures of the scar adhesions with protrusion of amniotic membranes. Now, intrapartum diagnosis, as I already told that if we select the patients for the VBAC, patient is in labor with the previous cesarean or previous scar on the uterus, we have to be very vigilant to diagnose the scar adhesions. Clinically, severe abdominal pain, particularly if the pain persists between the uterine contraction, that is very much important. Acute scar tenderness, vaginal bleeding, even patient is catheterized, then of course hematuria, cessation of the previous, then subsequently if we don't pick up this early adhesion, then it lead to the more widening of this defect and even rupture of complete rupture of the uterus. So subsequent features may be the cessation of the previously adequate uterine contraction, loss of stations and fetal presenting part, easily palpable fetal parts, and of course loss of the fetal heart sound that lead to the intrauterine death, and maternal side tachycardia, hypotension, and the features of the shock. So one more thing we can help in early diagnosis is the CTG. All the patient having previous scar and in the labor, we must do the continuous electronics fetal heart rate monitoring, and fetal heart rate abnormality, which can be picked up earlier in the CTG tracing, and that is seen in almost 70% of the cases. So it is very important findings, and we can give the it for the adhesion. And of course, many patients we are not able, asymptomatic patient not able to diagnose it during labor. During repeat cesarean section, we may find the scar adhesions. For example, these are the pictures we can already see many a times in the labors, and scar adhesion with protrusion of the membranes. And this picture is the scar adhesion is there, but the scar is on the placenta is on the lower segment. So this is the typical finding we see today in many cases of what we diagnose as a PAS. Now the management. Suppose asymptomatic antenatal scar adhesion, which is picked up by ultrasonography only. Patient have the no pain, no tachycardia, fetal heart rate, everything is absolutely normal. And patient, this could be diagnosed in late second trimester or early third trimester. And in such cases, with proper counseling, we can continue the pregnancy with strict monitoring, and we can reach up to the near term, that's 36 and 37 week, and then we can put the patient for elective cesarean section. But if we have the asymptomatic scar adhesion and patient enter in the labor, then there are more chances for the rupture. So that thing should be given to the patient. Then the symptomatic scar adhesions at any time during pregnancy or during labor, then we have to be very vigilant. Tenderness, tachycardia, fetal distress, all these are the common findings in such patients, and immediately we have to go for the repeat cesarean sections. And during repeat cesarean section or an exploratory laparotomy, most of the time that this wound will be open in the previous scar site only, which usually in the linear in fashion. So there are very rarely we need the hysterectomy, and we can have the repeat closure of the uterus. But during closure, remove the thin margins, which is not containing the muscularis layer, that contains only the serosal layer only. So just do the freshening of the margin and do the closure end to end with the muscular layer, not only with the muscular and one side serosal. Otherwise, it will give the weak scar in the subsequent pregnancy also. So that thing should very rarely patient comes late in postpartum diagnosis, necrous margin, then we may require the hysterectomy. Otherwise, most of the time scar adhesion, we can have the good repair and we can save the uterus. And further pregnancy, women with the history of adhesion should advise carefully when if she becomes again pregnant, subsequently careful monitoring antepartum period, and repeat cesarean is advised rather than the trial of the labor in subsequent pregnancy. Now the post-delivery, sometimes what happens, we have given the trial of the scar, patient deliver, everything is fine, but scar adhesion occurs in the last moment at the time of delivery of the baby. And this may not be diagnosed intrapartum also, and later on postpartum period may diagnose. If sometimes, though the routine exploration of the scar with the hand is not recommended, but if you do that thing and you find that there is a defect is there and patient is stable, no bleeding, then this is not an indication for the re-explorations or laparotomy or repair of the scar. But anytime if there is excessive bleeding is there after the delivery with previous scar on the uterus, then we have to go for the emergency laparotomy and exploration of the scars and repair of the scar. Now, second part of my talk is the scar monitoring in the VBAC. This is very practical one, and most of the time, why this topic is important? Sir has rightly said prevention is better, and particularly in the obstetric injury, it is our duty, primary duty of obstetrician to prevent such injury. So we have to focus proper selection of the patient, proper monitoring of the scar during labor, and if at all scar adhesion occurs, then timely exploration so that we have the minimal morbidity and mortality fetal as well as the maternal side. Now, why this is important? Because we all know that there are rising rate of the cesarean sections, and one way for reducing the rate of the cesarean is to go for the VBAC. Because I am practicing in the medical college monthly 250 to 300 cesarean sections. If I analyze the indications for cesarean section, then single most common indication is the previous cesarean section and patient not ready for the VBAC. So if you want to reduce the number of the cesarean section, then you have to start the practicing for the VBAC. And properly selected patient, almost 60 to 80% successful chances for vaginal birth after cesarean sections, with less than 1% chances for the scar adhesion. So this is very good thing. And so overall, if you compare with the elective cesarean, repeat cesarean section with the VBAC, then outcome is good in the properly selected, properly monitored vaginal birth after cesarean section. That's why it is very important. Now, how will you proceed for the VBAC? We will divide into three categories: antenatal assessment and counseling. Antenatal assessment for the proper selection is very important. Proper counseling is also very important. Then requirement of infrastructure and setting, what minimum requirement we will see later in subsequent slide. And of course, management at the time of admission and all the 4 stages of the labor. Now, the antenatal assessment and counseling, it includes the review of the operative note. That is very much important. Previous cesarean note is very much important. And we have to analyze the indications of the previous cesarean, location of the site of the incision, particularly previous note has mentioned that there are inverted TED incision, then we cannot select this patient. This is not the good patient for the VBAC. So proper operative evaluation of the previous operative note is very much important. Detailed obstetric history and antenatal record is very important because we have to exclude the contraindications for the VBAC. So both the things will lead to the proper selection of the patients so that we can select the patient which give the more success rate with minimum chances for the ruptures of the uterus. Now, what is the minimum requirement for the VBAC? 24 hours emergency cesarean section. There should be the anesthetists and the consultant should be ready on the site so that if scar adhesion features are there, we can go for the emergency repeat seizure. Blood bank, NICU facility, supportive one-to-one care nursing staff, either resident or one-to-one nursing staff must be there so that we can pick up the abnormal CTG tracings and all these things earlier and we can have the emergency repeat seizure section. Now, what we have to do at the time of admission? So, at the time of labor admission, again, detailed history, including detailed obstetric history, antenatal record, we have already mentioned at the time of the antenatal checkup. Review the operative note, rapid initial assessment at the time of admission, maternal pulse, BP, tenderness, there should not be there. Then obstetric examination, there should not be any contraindications for the VBAC, and everything is fine. Then we can do the proper counseling of the patients. Then we can take the written informed consent for explaining the benefit and advantage and disadvantage of the both approach of the delivery, repeat cesarean sections and the VBAC. And if the patient is agree for the VBAC, then take the written informed consent and proceed for the vaginal birth. Now, these are the findings which give the excellent success rate with the least chances for the rupture of the uterus. If the patient present with a spontaneous labor pain, vertex presentation, single-tone pregnancy, cervical dilatation more than 4 centimeter, or Bishop score more than 6, fetal head at the station 0 or lower, and if we have the facility and patient agree, then epidural analgesia and patient should be near town. So this gives the excellent results. So such patients definitely we have to offer for the VBAC rather than directly go for the repeat cesarean. Now, how to monitor during first and second stage of the labor during VBAC? So labor progress remains same whether the patient having the previous scar on the uterus or not. So there are no change in the monitoring of the labor. So the labor progress should be assessed by the same standard as in the woman with the unscarred uterus. But only different is in the management of the second and third stage of the labor is not different, but the VBAC patient should have the low threshold for ascension vaginal birth. So vacuum forceps should be minimized. Same way, low threshold for the induction and augmentation of the labor. So it should be done with very careful. And anytime we suspect the scar adhesion, we have to emergency, we have to shift for the labor. So this is the standard protocol of the labor management, that is WHO labor care guide that we have to follow in all patients if you go for the VBAC. And now, what are the clinical features which might suggest that patient may have the scar adhesion or developing scar adhesion, so that emergency we have to shift for the cesarean. So most important constant finding is the fetal heart rate abnormality. That's why the electronic fetal heart rate monitoring is must for the all cases of the VBAC. So almost 70% of the cases of scar adhesion, we can pick up the fetal heart rate abnormality, and if you shift emergency, then there are least chances for the compromised fetal-maternal outcome. Other findings are severe abdominal pain, especially it persists between the uterine contraction, acute scar tenderness, vaginal bleeding, hematuria, and of course, late finding are the cessation of the previously adequate uterine contraction, loss of stations, easy palpable fetal part, and maternal tachycardia, hypotension, all these things. Now, something regarding the epidural labor analgesia in VBAC. There are controversy, or some people believe that if we give the labor analgesia, then how we can find that person may have the developing scar tenderness and all these things. But study has shown that labor analgesia is not an contraindication, and fetal distress is the constant finding. Even tenderness are also there, and requirement of increased dose of analgesia. Suppose person is comfortable with epidural analgesia and said that now I feel the more and more pain, then we have to be vigilant. This may be due to the added pain due to the scar, developing scar adhesion. And another advantage of this labor analgesia is that if we suspect the scar adhesion or fetal distress, then same labor catheter, epidural catheter can be used, and immediately we can go for the cesarean section in the epidural labor anesthesia. Now, another controversial issue is the induction and augmentation of the labor. Again, induction and augmentation is not contraindicated, but the study shows that success rate of the VBAC is less if we induce the labor and then proceed for the VBAC, or if any person in the labor and not progressing properly and we go for augmentation, then success rate is less and there are little bit increased chances for the rupture. So that thing should be conveyed to the patient before proceeding for induction and augmentations in cases of the selected cases for the VBAC. And at all, if we decided for the labor induction, then mechanical method like amniotomy and Foley's catheter should be given prior over the prostaglandins. And misoprost for the pre-induction ripening or augmentation is a little contraindicated in cases of VBAC. We have to switch over to the oxytocin, which have the little bit good control as compared to the misoprost or other prostaglandins like gels and all these things. Now, one more second stage of the labor controversial issue is the assisted vaginal birth in the VBAC. If the patients, we are giving the VBAC, head is on the perineum, all the criteria for outlet forceps are there, instrumental deliveries are there, then selected cases for the vacuum and forceps are not contraindicated, but the person must have the good experience on all these techniques. Otherwise, improperly selected cases and improper technique can lead to the scar adhesion, which is not till there second stage of the labor. Now, what is difference in third and fourth stage of the labor? Active management of third stage labor is same as that of the without scar on the uterus. But remember that in cases of delayed delivery of the placenta or retained placenta, don't directly jump for the manual removal of the placenta. Do the repeat bedside ultrasonography with color Doppler and explore that this placenta should not be on the scar, and if placenta is on the scar, we have to rule out the past, that is placenta accreta spectrum disorder. If such kind of suspicious is then directly proceed for the laparotomy rather than manual removal, difficult manual removal of the placentas and subsequent bleedings and all these things. And another thing is routine uterine explorations after the VBAC is not recommended. For example, patient delivered placenta, membrane, everything is fine. Then don't introduce your hand and see for the scar, whether the scar, my scar is intact or not. So that may lead to the thin scar rupture, which is not ruptured at the time of the delivery, and you may rupture by manual. So that is not recommended. And your clinical finding of scar adhesion is also not correlating appropriately. So just deliver the, wait and watch, deliver the placenta membrane, there are no bleeding, no any other complaints, then don't explore manually the scar, whether it is intake or ruptures. But anytime excessive bleeding, signs of hypotension, then you need promptly to complete the evacuation of the urinary tract, and if needed, then exploratory laparotomy. Then, if the uterus is explored and you feel that there are scar adhesion, but the no active bleeding, then also don't need to go for the exploratory laparotomy. Now we will go for two interesting cases that I have managed for the scar adhesion. Case 1, gravida 2, abortion 1, 24 years old lady with a 5 running months of amenorrhea came with a complaint of acute lower abdominal pain. In her past history, there is abortions at 6-week DNC done before 4 years. Then 3 years of the secondary infertility, for which she underwent the histolaparoscopy for secondary infertility before 1 year. Currently, she has the 5th running months of amenorrhea and acute abdominal pain. At the time of admission, her pulse 120 per minute, BP 100/70, pallor +1, and per abdomen uterus 20B with minimal tenderness was there. And in per vaginal examination, no active bleeding, was closed, but uterus was tender in bimanual examination. Bedside ultrasonography, single intrauterine live fetus, 19 weeks, 4 days, corresponding with 19 weeks and 4 days of gestational age with minimal free fluid. And myometrial thinning at the level of the fundal region was noted. So patient was kept under observations, conservative management, blood was sent for the cross-matching. Patient admitted in the labor room. But after admissions, after 3 to 4 hours, pain was worsening and there is increased tachycardia and fall of the blood pressure. So decision for emergency laparotomy was taken. And this was the finding on table. So from the fundal region, there is a very thinning and bulging of the amniotic sac is there. So that's suggestive of the adhesion from the fundal regions. And once we delivered the baby from this, and this was the linear giveaway scar was there. And then later on, retrospectively, we asked for the all papers of the histolaparoscopy. Then in hysteroscopy, they have the septate uterus and they have cut the septum. So probably the overcutting of the septum, which make the transverse thinning at the site of the septum, and which may give the give way. So it is not only the previous cesarean sections which can give rise to the scar adhesion, but any surgery on the uterus, including operative hysteroscopy, can also give rise to such thing. And ultimately, we have removed this scar. Then we have done the freshening of the margin and double layer closure at the fundus was done. Okay. Now the another case, gravida 2, para 1, abortion 0, previous LSCS. At 34-week patient present with a preterm labor pain. Previous cesarean, second gravida, 34-week with preterm labor pain. Vitals were normal. For abdominal finding, 32-week pregnancy, cephalic 3/5 engaged. Fetal heart sound 140 per minute, normal. Uterine contraction, mild contraction was present, and there was no scar tenderness. Patient was admitted, and in vaginal examination, 4 centimeter dilatus, almost nearly 80% effaced. PP vertex membrane present and station 0. So after admission, within 4 hours, patient was delivered with the spontaneous labor and preterm delivery of male live 1.7 kg. Everything was fine, but due to prematurity, baby was needed to admit in the NICU. And placenta and membrane delivered without any problems. Patient was kept under observation in labor for 6 hours. There are no bleedings. Everything was fine. So we have shifted the patient to the postnatal ward after 6 hours. The baby was admitted due to prematurity in NICU. Everything was fine, so we discharged the mother on 4th postnatal day. But for the prematurity, baby was admitted in NICU. On 10th postnatal day, mother came in the OPD and having complaint of the weakness, giddiness, and fever. And temperature was elevated. There are little bit tachycardia was there. Blood pressure was normal. For abdomen, uterus was again 20-week size. So it is sub-involution of the uterus after 10th day preterm delivery. It should become the nearly at the fundus, should be at the level of the symphysis pubis, but it is higher. And tenderness was there. No guarding and rigidity. In vaginal examination, vagina was hot with offensive lochia was noted. So we diagnosed as a post-delivery sepsis, peripheral sepsis, and again admitted the patient and kept on the antibiotics, higher injectable antibiotic, triple antibiotics injectable, and other investigation was sent. But in ultrasonography, uterus was enlarged with the empty uterine cavity, and there was a hematoma of 6 by 8 centimeter size between bladder and lower uterine segment, and moderate free fluid was noted, which having the multiple echoes suggestive of the developing pelvic peritonitis. So it is after the ultrasonography or diagnosis it was scar adhesion with hematoma and developing infections. So we have counseling the patients and taken for the exploratory laparotomy, and hematoma was removed. Scar adhesion was there, which was margin was freshened, and the repair of the scar was done. So the scar adhesion, it is not that it will be present at the time of labor, at the time of VBAC only. It may be present in antepartum period, may have them during the VBAC, or even many patient may present with such cases like the postpartum presentations, which scar adhesion occurs at the time of delivery, but presentation will be in the later on postpartum period also. And patient may have the scar adhesion with the hysteroscopic surgery or even after the myomectomy. Similarly, interesting case I have managed, that is the patients, is primary patients present in the emergency at 2 o'clock midnight having the acute abdominal pain. So patient was primary, so we are not thinking what is the cause for the acute abdominal pain. And in bedside ultrasonography, there are intrauterine fetal death, tenderness, guarding, rigidity, tachycardia, hypotension. So either it might be the rupture uterus or it might be the abruption placenta. Emergency exploration was done, and surprisingly we found the linear scar at the fundal region, and rupture was there from there in primary patients. And later on we have everything was then later on next day we have discussed with the patient's relative and asked regarding what patient giving only state that some laparoscopy was done in the childhood before marriage, so they have no papers. And later on we have asked for the paper, then this was the myomectomy done with 8 centimeter size of the fibroid at the fundal region, and that scar was the giveaway. So these are the very interesting cases for the scar adhesion. So we detailed history, previous record are very much important. So that's all regarding the scar adhesion. Once again, thank you, Dr. MC Patel and team, for giving me the opportunity. And I invite all of you for the AICOG, 69th AICOG at the Surat in 2027 January. Thank you.
Thank you. Now I would request Dr. Ruta to please speak a few words about this talk and give the final comments. Dr. Ruta, please.
Yeah.
Thank you. At the outset, I would like to thank Dr. MC Patel sir and the team for giving me this opportunity. When Jewel of the Surat, Dr. Ashwin Vachani, head of the Department of Swimwear, speaks, what students have to, they shut their mouth. I just 2 lines I'll say. From diagnosis to monitoring to management, excellent. I don't have any other comment to say. But sir very well explained the importance of USG in diagnosis. In monitoring of scar dehiscence also, sir very well elaborated all the points. And myself, I was also very much, I was not interested in VBAC. Frankly telling, I'm also afraid of VBAC. But when sir spoke such a nice way and sir gave me courage that we can go for 60 to 80% success rate he gave when you choose the case very appropriately and selectively. So I think from tomorrow onwards, we all should think about VBAC when appropriately case selection is done. Very nice, wonderfully explained, sir. Thank you. Thank you very much.
Thank
Thank
you.
you.
Thank you.
Thank you, Dr. Rupa. Thank you, Dr. Ashwin. And if there are any questions from the house, Dr. Monica, then otherwise we will go to
answer the
section 2.
questions in the chat box because we need to still have one more session and the panel discussion to go, ma'am.
Thank you.
Okay.
I have, can I come in? Can I come in?
I now
Yes,
hand
sir.
over the session 3 to the next coordinator.
Slides of the next session, please. तुम आए क्या?
नहीं मी तुमच्या सब्जेक्ट सबमिट केलं. Just come. You need to do it. In case anything extra.
Yes, Monica, who is taking?
Requesting Dr. Monica Gupta, madam, to please introduce the chairpersons.
Is she there?
Shatabdi, if you are there, please introduce, no?
I'm there, Monica.
Yeah, please.
You
Yeah.
can.
Yeah. Okay. Yeah. We'll proceed with the third session. I would love to introduce Dr. Percy Kharas. Dr. Percy is the CEO of Excellent IVF and ICSI Center at Valsad since 2010. He's a practicing gynae and infertility specialist at Valsad since 1986, and he's one of the pioneers in the field of infertility work at South Gujarat. And also, he has many honors like he also has a Center for Sexual Medicine at Valsad. He's heading that since 1991. Welcome, Dr. Percy, sir.
Thank you.
Next.
Yeah, I would also like to welcome Dr. Vipul Kapadia, sir. Sir is the director of Ramaben Hospital, Navsari, also the director of Namaha Healthcare at Mumbai, and the past president of the SOGOG, also the past president of Navsari Medical Association. Welcome, sir. Our third chairperson is Dr. Jayashree Jena Kapadia. Ma'am is a senior consultant, obstetrician, gynecologist, and infertility specialist at Life Care Multi-Speciality Hospital and Shri Fertility and IVF Center at Daman since 2001. She has been she has UGPG study from government medical college. He has conducted many health awareness programs and free health checkup camps, as well as given many presentation in many state and national conferences. Welcome, ma'am. I would request Percy sir to kindly introduce MC Patel, sir, our next speaker.
Yes, sure. I would love to do that. Well, can you hear my voice, everyone, please?
Yes, but in
Yes,
short.
sir. Yes, sir. We are clearly heard, sir.
Okay, fine. To introduce Dr. MC Patel, it's really a privilege to me because he is the main person behind this whole, I would say, 204 webinars and he is one of the main speakers today. And regards his highlights, what should I say? Candidate for Foxy President Election 2026, we all know. And I think this is now high time Dr. MC Patel should be elected as President Foxy 2026, because he is the most deserving person for this post. And I do not think why he should not be the president now. It's high time a person of his caliber, his knowledge, and his work to be elected on this post. Regards highlights of his career, I don't think he needs an introduction from a person
you,
like
sir.
me.
Thank you, sir. Thank you.
Yes, he has been
Any opening remarks from two other chairperson, and then I can switch over to subject.
Yes, I think that would be the best thing.
Yes. Vipul Kapadia sir and Jayshree Jana madam. Any opening remarks about the subject, and then I will straightway go to the subject.
This subject is a darling of Dr. MC Patel. And I don't think anyone else other than MC Patel in the country can really highlight and teach us something on this subject. Any of the other chairpersons, please, as Dr. MC said.
I can see Vipul sir. Vipul sir, if you could say a few words, please.
Am I audible now?
Yes. And till my request to host to allow me to share my screen.
Yes, sir. Vipul sir, you are audible, sir.
Yeah, fine. I don't think I should be taking a lot of time from Dr. MC Patel's deliberation. Who does not know Dr. MC Patel? And for the subject that he has selected, the medical legal issues in obstetric injuries, one of the most burning things which we have faced. We all have faced one time or the other if you are in practice for more than 5 to 10 years. I think Dr. MC Patel is the right person to deliberate on this, and we should hand over the whole mic to him.
Thank you, sir. So please allow me to share my screen. Host.
Yes, sir. You can now share the same.
But I am unable.
I have made you co-host also, sir.
Because when I click this button, share, then this screen comes UCAM, Micro Office System, Micro Edge, share options, share sound, optimize.
Yes, sir.
Is it seen?
Yes, sir. Now it's visible.
And it is full screen.
Yes, now it's full screen, sir.
Okay. But screen is not running. Yes. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and who have helped me to continue this our educational activity. At the same time, I would like to thank you all because you stood with me during my election campaign for President Foxy last year. Though I lost, but I believe in this. This is rightly written by Shraddhe Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end, but a new beginning. Journey to South Foxy continued with renewed patience. So thank you everybody for everything. And still my commitment is there. Wherever you are, I will be there. Promise to reach the unreached. And I will be seeking same blessing, same support, same guidance for and the same post President Foxy next year, election year 2026. And coming to the subject straightway, legal issues in obstetric injuries or birth injury. So let us see with some statistic from USA. 78% gynecologists should at least once, and out of those 37% gynecologists should on 3 or more occasions, and nearly half of the malpractice claim relates to obstetrical problem. And as far as our part is concerned, malpractice use and allegations of negligence in obstetric cases, especially related to maternal and fetal birth injury, are rising in India. If we go with statistics from honorable courts, then we see the rising trend as far as litigation related to this subject is concerned. And patients with high risk pregnancy are being viewed as a potential courtroom adversaries, because this is taken that way. If it is high risk pregnancy, their potential cases may end up into litigation. Let us see few of the cases. It was a patient delivered baby of 4.5 kg vaginally by forceps, and it ended into brachial palsy. Case was filed. Defense on part of doctor was, it was complicated case. Patient refused for consent for cesarean section, and the baby was getting asphyxiated. So we went with forceps, and ultimately it happened. But as far as inference on part of court was that patient was admitted at 6 a.m. Delivery started at 4 p.m. No investigation in between from 6 a.m. to 4 p.m. was the inference held by the court. There was no sonography and no evidence that consent was refused. So it is a very vital point. Doctor told that patient and patient party didn't give consent, but observation on part was court was no evidence that consent was refused. So here comes a role of negative consent. Whenever you advise something and patient party refuse, then you have to mention in case paper and get it signed by patient or patient party that we are not giving consent. But many a time patients and patient party are not ready to give negative consent also. So in this situation, you can have signature of any visitor of your hospital, any co-patient, but at the same time, you will have all the detailed information about that person who have signed that before me it was explained to patient and patient party and they refused to give consent. So negative consent at its own role as far as litigation party is concerned. So in this particular case, case was decided in favor of patient and compensation of 1.75 lakhs was awarded in favor of patient. Let us see one more comments from this particular case. Case law cannot be adhered to a standard of practice. So it is very clear that law doesn't teach you medicine. How to treat patient, we have to treat patient as per standard protocols in that very given situation. Medically, it is known that sonography is not accurate indicator of fetal weight as perceived by common men and court many a times. So we have to convince court that US is not the exact indicator as far as fetal weight part is concerned. Of course, it can give approximate weight, but not exact. So in case, can it predict disproportion or difficult delivery? This was also one more comment. And in rural area, many a time all these facility may not be feasible. So in this case, particularly as a medical legal expert, I would say it was poorly fought case, poorly presented case. So in court of law, proper presentation of your case is equally important. Let us see one more case. Again, it was forceps delivery and it entered into uterovesical fistula. So defense on part of Dr. was it occurred during process of delivery and due to long-standing head at the same position, it was pressure necrosis and ultimately it led to uterovesical fistula. But in this case also, court didn't took that consideration, defense on part of doctor, and doctor was liable for this injury and case was decided in favor of patient. So what is birth injury? As far as maternal part is concerned, obstetric anal sphincter injury, nicely covered by Dr. Roji Ahia madam, and all other maternal injury, vulval, vaginal, perineal, laceration, tear, hematoma, paraurethral, urethral and bladder injury, VVF, RVF, cervical trauma, uterine rupture, repairable or ultimately uterus to be removed. But these are some injuries which may lead to medical legal problems in future. As far as fetal part is concerned, fetal asphyxia or birth asphyxia, kyphelohematoma, fracture of skull, long bone and clavicle, earth palsy, injury during breech delivery, sharp cut on fetal body at the time of cesarean section, and perinatal death. These are the situation. But it is very common that fetal injuries, especially those leading to permanent liability, are more likely to end up into litigation. So we should be very careful in this type of situation. So which are the areas as far as litigation part is concerned? And common allegations for litigation in this type of situation is improper diagnosis of fetal distress leading to delayed delivery, improper monitoring of process of labor leading to complicated labor, improper interpretation of CTG, improper application of instrument for operative delivery, and improper conduction of labor causing perineal tears and improper repair of those tears. These are common allegations as far as litigation related to obstetric injuries are concerned. As far as role of cesarean section is concerned, we are in a very tricky situation because on one side, many a times media is having a high cry and very loudly that cesarean rate is increasing tremendously. And on other hands, at the time of facing litigation, many a time there is a inference held by the court or comments by the court, litigation for not doing cesarean section in time. So we are in very tricky situation as far as cesarean section part is concerned. So which are the reasons for litigation in this type of situations? And you may end up into litigation. Which are the common allegations? Delayed in diagnosis, investigation or treatment. If at all some injury occurred, then it should be diagnosed well in time and it should be dealt with accordingly. Misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigation, no proper consent, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all we have to transfer patient to another center, and if there is a delay for any reason, then it could be one of the causes. Complications, morbidity, maternal and or fetal, and in few of the cases mortality, maternal and or fetal. Overcharging. Nowadays this has become one more allegation that tremendous expense against unexpected result. So whenever you are facing this situation, we should be alert as far as litigation part is concerned. But whenever you are facing any litigation, usually you have to face this some questions. And very important question is, was it preventable? Say for example, if it is ended into obstetric anal sphincter injury. So very important question will come, was it preventable? And usually you cannot say no. So if it is yes, then what did you do to prevent it? So you will have to say which measures you took to prevent that probable complication. And in spite of all your care, caution, if you couldn't prevent, because in all the situation, it is likely that you cannot prevent. So why you couldn't prevent it will be one more question, and one more important question will come. If at all you couldn't prevent, then did you diagnose that complication well in time? And very important question, did you manage that complication way in which any prudent doctor would have managed? If at all any obstetric injury happened, then did you diagnose in time and did you manage way in which any prudent gynecologist or doctor would have managed? Is the main question you have to answer and satisfy honorable court. And naturally prevention is always better than cure, but prevention may not always be possible. So as far as injury to baby during cesarean section is concerned, during cesarean section proper care not to injure presenting part of baby, and few of our gynecologists advise that pick up between two Ellis forceps and then little cut in between and splitting remaining fibers with artery forceps not to end up into injury to presenting part of fetus. Every complication of obstetric injury is potential threat as far as litigation is concerned. And look like avoiding medical legal problems in this type of situation in our practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? Practice foreseeability, anticipation, good communication, proper consent, and proper documentation, and you may simply sail through. Court and law expect from us anticipation and foreseeability. You have to anticipate certain complication. Just we saw in first case that it was 4.5 kg baby and they tried to deliver vaginally. So in this type of situation, one should anticipate that she may end up into injury like anal sphincter injury or so, and we should be readily available to deal with that very situation. So foreseeability and proper counseling. So whenever you are dealing with this type of cases where obstetric injuries are likely to occur, then at the time of counseling, we have to explain that part also. And whatever we explain, it should be in a very simple language. Avoid medical jargon. So we should explain in a simple language, and no rosy picture about result, no tall claim about result. Because when we are dealing with this type of situation, just mentioned 5 kg baby delivering vaginally. So in this type of situation, no tall claim, no rosy picture, because many a time we consider result like Aishwarya Rai, but it may turn like this at any time in our obstetric practice. And this is very important part, post-delivery counseling. If at all you met with any complication like, say for example, anal sphincter injury, then post-delivery counseling is equally important about injury, which kind of injury you met with, and repair, how you took care, and how you repair it. If you have not repaired and still you have to repair, and if you have to involve some senior person, that can also be counseled with patient party. If at all patient is to be shifted to another center, then also we have to counsel party with all future treatment plan. So whenever you are facing any obstetric injury or birth injury, these are the very vital part as far as post-delivery counseling is concerned. So proper communication and proper documentation is very much must. Because in this very famous case of C. Jaipal Reddy versus Padmini Veluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your counseling, of your communication. So whatever you counsel, whatever you communicate, each and every point should be entered in consent paper, and then patient party has to sign. And once they sign, it becomes a documentation of your communication, because whatever you have communicated is documented in that consent paper and signed by patient and patient party. And whenever you offer all those documents in court of law, it becomes communication of your documentation. But you have not to remember all this. Simply visit FOGSI website, and at FOGSI website, under FOGSI uniform consent, there are 30 different consents available, and you can simply download and use those consent. In those very consent for normal vaginal birth is also there, forceps delivery, vacuum, cesarean section. So all consents are available and you can download and use it. We have prepared those consent in two parts. Part one is information about surgery. Say for example, if you are dealing with a cesarean, the name of procedure, cesarean section. Meaning, what is the meaning of cesarean section? To cut open abdomen, to cut open uterus, and to deliver baby. In this type of simple language, this consent is prepared. Purpose, indication, description of procedure, benefit of procedure, alternative. If patient is not willing to go for that very procedure, are there any other alternatives? We have to explain that also. Consequences of refusal of procedure. If patient is not willing to give consent, then which are the consequences of refusal? We have to explain and outline the substantial risk involved with anesthesia and our procedure or surgery. We have to explain possibility of excessive bleeding or blood accumulation, possibility of infection, possibility of injury to surrounding structure. And if we have mentioned in the consent paper about this possibility of injury to surrounding structure, and if patient has signed the document, it becomes a good defense in our favor. Every individual has a different way to cope up. We have mentioned that also. very rare condition like allergic reaction to drug we have mentioned, and neonatal outcome with possibility of neonatal morbidity, and in few of the cases mortality we have mentioned. And part 2 is undertaking. So whatever we have mentioned in part 1, patient will go with undertaking in part 2. But very important part is this, which is shown in red color. If we have to go beyond the scope of consent given by patient, and if patient has already given consent that in this type of situation you will discuss with Mr. So-and-so or Mrs. So-and-so waiting outside operation theater or labor room, and if they give consent, it is as good as consent given by me. And with consent of those persons, we can very well proceed accordingly to deal with the subject. But if patient has given consent like this, in order to save life, it may even be necessary to do additional surgery or procedure and prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. And at the end, we have to go with a signature or thumb impression of patient and 2 witnesses, one on part of hospital and on one part of patient, and signature of doctor is must. So this type of consent paper we have to keep ready. As far as records are concerned, we have to keep them up to date because they are always at your rescue. So what was done, nothing was neglected, given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. This is also a very important part, and that is discharge card. Give proper instruction to the patient. Is it important to give instruction about diet to be taken, medicine to be taken, exercise, follow-up, and references if at all required? Yes, in this case, of course, this is not related to birth injury, but it was preterm delivery, premature delivery, and baby was admitted in NICU. But at the time of admission, nobody advised to go for opinion from ophthalmologist, and ultimately baby ended into retinopathy due to prematurity, and case was filed. And in this very case, 1.8 crore compensation was awarded in favor of patient, and out of those 1.73 was awarded by government of Tamil Nadu because it happened in government hospital, and rest of the amount was to be paid by neonatologist. Luckily, gynecologist was not made party in this particular case. So in discharge card, proper instruction, including references, are very much important. So this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So if you have all the alternatives, but if you do not utilize those alternatives well in time, then you may end up into problem if at all you are facing litigation. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way. So to conclude, minimizing birth injury claims, labor room, labor ward protocols we have to strictly follow, adequate supervision and monitoring during antenatal period, during delivery, and even after delivery and during surgery also. Proper communication, counseling and consent, proper documentation and record keeping, multi-speciality approach. Whenever it is needed, do not hesitate to call senior colleague in help because it shows your concern to save life of patient, to manage patient efficiently, and it becomes a good defense in your favor. In-time reference is very much must. Indemnity in era of this CPA, it is very much must, and you have adequate cover of indemnity, and audit of your own case. So we can audit, and we may not end up into same problem in future for the same reason. So if you want to sleep like this, take tender care of your patient, strictly follow protocols as far as delivery part is concerned. Pray Almighty God before going to sleep, and keep my visiting card below your pillow. So if this video runs, so with regards, salute to all the societies who have joined and all the faculties who have joined this on my request and invitation. Thank you very much. Please do not assume, please ask any question, any query if time and chairpersons permit, or put your question in chat box. I will answer those questions in chat box. So thank you very much.
Thank you, Patel sir. It was a quite elaborative talk, and we wish you all the very best for all your future endeavors. I would now request our chairpersons, Percy sir, Vaibhav sir, and Jana madam to please give their concluding remarks.
Can I start with it, please?
Yes, sir.
Well, it was an excellent exposition by Dr. MC Patel. And what else do you expect? He is a master of this particular subject, a well-known personality not only in India, but even in entire Asia. And there are so many world countries who now know about his expertise in this particular topic. What we are concerned is he always speaks with the Indian touch. Some of the Indian rules and regulations are very much different than the Western world. And his knowledge and his expertise in these Indian rules and regulations has helped hundreds of people. There are practically every week, there is someone or the other who is phoning him from India or outside India and asking him about such matters. So there is nothing much to speak. It was an excellent talk on this subject of birth injuries. And I wish him all the very best for his becoming our president of FOXI in the next election. And I wish that every one of you and all FOXI members really work very sincerely to see that this man wins the post of president. Thank you.
Thank you, Percy sir, for your kind words and all the blessings. Thank you, sir.
Vipul sir, over to you. Sir, please unmute yourself.
What can I say about Dr. Patel's lecture? I've heard him many, many times, but every time I've come out learning something new, something better. And I feel safer only if I follow all his instructions and all his directions.
Thank you.
All the best, Dr. Patel. All the best for your future endeavor as president of FOXI.
Thank you, sir. Jayashree madam.
Yes. What to say? It was a much needed lecture. In the today's era of CPA, Consumer Protection Act, we should be very vigilant. And as you said, sir, we all should have the proper consent, proper documentation, counseling and communication. These 4 things, giving discharge cards and explaining it properly. These small things which we miss because we are so much worried about the patient and busy taking care of the patient, and we give this to the supporting staff or the junior nurse, and there we fall short. And suppose we have not communicated properly, that backfires us. So these small tips which you have given will be very, very beneficial to us. Thank you so much for such in-depth and excellent lecture, sir. Thank you so much.
Thank you, madam. Thank you.
Thank you, Patel sir, and thank you, chairpersons, for an excellent deliberation. And as sir has rightly said, documentation is the only savior in the court of law. I would now request Shatabdi to move ahead with the next academic part, that is the panel discussion.
Thank you, Monica. Thank you, MC sir. Indeed, an elaborate lecture by you, as always. It's so wonderful to listen to you each time. After those 3 very nice talks by 3 wonderful speakers, we'll move on to the panel discussion. We have a very important and pertinent panel discussion today. It's on case scenarios in obstetric injury. Can I have the slides? We have Dr. Narendra Gajjar sir and Dr. Chintan Thakkar as the moderators. Can I have Dr. Narendra sir? Yeah. Dr. Narendra sir is one of our.
Yeah, I am sharing the slides. Please
Yes.
wait.
Yes, sir. So should I continue?
Yeah, please.
Okay. Thanks. Okay. So our moderators are Dr. Narendra Gajjar sir and Dr. Chintan Thakkar sir. Dr. Narendra Gajjar sir is one of the past presidents of SOGOG. He has received many prizes and awards for academic achievements, and he's participated in many state and national conferences as various speakers, panelists, moderators. Also has been the organizing chairperson of West Zone Yuva Foxy 2021. Our next moderator is Dr. Chintan Thakkar sir. Dr. Chintan Thakkar is the current president of SOGOG. He has done many community projects like health checkup camps, educational seminars, and public awareness programs. His key areas of interest are laparoscopy and infertility. He is past president of IMA Bharuch and immediate past president of the Bharuch Obs-Gynae Society. Welcome, Chintan sir. Our expert panelists for the session are Dr. Praful Doshi and Dr. P.K. Dheer. Dr. Praful Doshi is a director at Me and Mummy Hospital at Surat and the chief consultant at Blossom IVF Surat. He has been a professor of gynecology for the last 18 years at Jamnagar and Surat Medical College. Welcome, Praful sir. Dr. P.K. Dheer sir is a senior consultant of OBGY, infertility and endoscopy. He has the credit of giving the first test tube baby to Bharuch in 2003. He has been the president of BOGS 2006 and the president of SOGOG 2007. Also the founder president of Bharuch Menopause Society. Welcome, sir. We have 9 very interesting group of panelists over here. Our first panelist is Dr. Vaibhav Kapadia. He is a consultant in OBGY at Ramaben Hospital at Navsari, also the director of Nama Healthcare Mumbai and president of the Navsari Obs-Gynae Society. Welcome, Dr. Vaibhav. Our next panelist is Dr. Kokila Desai ma'am. She has been practicing as a chief infertility specialist at Shivam International IVF Center at Surat. She has advanced training in reproductive endocrinology from Germany, also a fellow in reproductive endocrinology from Germany and senior consultant at Shivam Hospital and Maternity Center. Welcome, ma'am. Our next panelist is Dr. Quresha M. Qureshi. Ma'am is a senior practicing gynecologist practicing at Pardi, Valsad for the past 33 years. She is working as an IVF and infertility specialist for the past 7 years. Also the franchisee head of Indira IVF Valsad. Welcome, ma'am. Our next panelist is Dr. Darshan Wadekar. Dr. Darshan Wadekar is a gynecologist and obstetrician at Mumbai, president of the Surat Obs-Gynae Society 2022 to 2023, also the organizing secretary of AICOG 2027. Welcome, Dr. Darshan. Our next panelist is Dr. Hiral Pandya. Dr. Hiral is practicing as a gynecologist and obstetrician for more than 20 years at Sevashram Hospital at Bharuch. Also, she is the president of the Bharuch Obs-Gynae Society, Gujarat. Welcome, Dr. Hiral. Our next panelist is Dr. Sheetal Parag Talekar. Ma'am is a consultant obstetrician and gynecologist at Shalby Multi-Speciality Hospital, Vapi, and the president of Vapi Obs-Gynae Society 25-26. Welcome, Dr. Sheetal. Our next panelist is Dr. Aditi Nadkarni. Dr. Aditi is a specialist in fertility and IVF fetal medicine expert and endoscopic surgeon and director of Nadkarni's 21st Century Group of Hospitals at Valsad, Vapi and Kilapadi, practicing infertility and high-risk obstetrics and gynecology since more than 15 years. Welcome, Dr. Aditi. Our next panelist is Dr. Sarfaraz Nawaz Qazi. Dr. Sarfaraz is an oncogynecologist and also a painless delivery endoscopy and infertility specialist and the director at Navjeevan Women's Hospital at Himatnagar, consultant gynecologist, endoscopy and infertility specialist since the past 20 years. So over to you, kindly moderators, Chintan sir and Prakash sir, for carrying on with the session.
Thank you very much, madam, for that nice introduction. I think without without wasting a lot of time, we should directly go for this very important and interesting session for today's discussion. Along with my co-moderator, my senior and always legendary personality, Dr. Narendra Gajjar sir. We do have the treasure of, we do have experts like Praful Doshi sir and Dev sir, who are teachers, great teachers, and we always learn from them things, and the treasure of panelists. At the outset, before handing over to Gajjar sir, I would like to express my sincere gratitude and thank you very much to Dr. MC Patel sir. Sir, you have started a great job of happy learning and completing 204
webinars is such a huge task. So the entire Gujarat and entire India, I think, owe to you for such a great academic session. It does require a lot of dedication and hard work and compassion and everything, the efforts that you put in spite of you're such a busy person. We appreciate your efforts, sir, and we thank you from the bottom of the heart for arranging such nice things. And we wish you all the best for the upcoming elections. And I think we should all be working hard, because it would be our win. Dr. MC Patel sir's win would be. Once more, thank you, sir, for bringing. This is a special webinar which brings the all societies, all 5-6 sisters of the South Gujarat together, and discussing the very important aspect of our faculty, our field, which is quite often neglected. Because we all are having much inclined towards all the glorious branches like sonography and laparoscopy and everything, but this is the basic thing, and this is our identity. The obstetrics is the thing from which we are known for. So thank you for bringing about such an important topic for this webinar. If we want to ask ourselves that when do you suspect there is injury or there is a birth injury? So I think there are few points. As such, as an obstetrician, we should be so much vigilant that after every delivery we should be exploring the vagina and the cervix for any tears or any injury. But specifically, whenever there is a precipitated labor, or there is a big baby, or there is a prolonged second stage, or any amount of PPH, or any abnormal appearance like what you see in inversion of the uterus or third or fourth degree perineal tears, whenever the vulva or vagina looks abnormal to you, always suspect some form of birth injury. We all know that our labor room is an ICU for our gynecologist. So we don't have dedicated ICUs. Whenever our emergency comes, it happens in our labor room. So I think if we want to prevent or if we want to manage the injuries at birth in an efficient way, then probably there should be some minimum requirement that we should have. First of all, there should be a good light. I mean, this is a part which is being neglected by so many things, so many people. Then the all instruments, you should regularly check, because at the middle of the night, it happens sometimes that, you want to explore the cervix, but you don't have enough sponge holders or speculum. So all the instruments which are at your help in the time of emergency should be checked regularly. The labor room should be equipped with monitors, including fetal monitors, the maternal monitors, and the monitors for the baby and everything. So the equipment is also a vital part. You should be having all the drugs, a PPH kit, a PPH, the drugs and everything should be ready to tackle any sort of emergencies. The first and the foremost important is your vigilance. Never consider yourself a master, because whenever you have that attitude that okay, now I'm the boss and I've tackled so many things, the nature strikes you. So always be vigilant, no matter whatever 1,000 number of cases you have dealt with, and a good staff, which is a very vital thing for you in the area in your labor room. And the last thing is good relations with your colleagues and your seniors, because you can need them at any middle of the night. So I think this should be a basic requirement if you want to prevent or tackle the birth injuries nicely. I would hand over the stage to Dr. Narendra Gajjar, sir. Sir, please.
Thank you, Dr. Chintar. At the outset, I would like to say thanks to Dr. MC Patel, along with all the best wishes for the President Foxy 2026. And at least our Gujarat should have that honor. Thank you very much. Now, I would like to know who are our panelist. Monica? Hello?
Sir, Hiral.
Yeah, Hiral. Then next one. From the list of participants, I think.
Sure.
Sir,
Dr.
in another
Yeah,
5 to
Sheetal.
10, 5 minutes, I'll
Sheetal.
have to go to OT. So I'm there in the start for 5-10 minutes. I'll be there.
No problem.
I'm here.
Okay. Then Vaibhav is there.
I'm here. Vaibhav is here.
Yeah, fine. Kokila madam, is she there? Kuresha madam, I think she would be here.
Yes, I'm
Yeah,
here,
you are
sir.
there. We are always together.
Just within 1 minute, I will be there. One
Okay,
minute,
okay,
in the
no
round.
problem. Dr. Darshan?
Yes, sir.
Okay, fine.
Sir, I'm there.
Aditi and Vaibhav not coming.
Sir, we'll call them and ask in a minute.
Okay, fine.
I'll
Whenever
call
they
them.
are there, they should
Yes.
send a message.
Yeah, I'll tell them.
And I know Dr. Sarfraz is always there. He's so active. I expect he's there. So, without wasting time, next slide. Right. So, such type of pictures we see often. Doctors are coming on roads and they need protection. And why this situation arises? Because of the increasing litigations, especially in obstetrics. And young obstetricians, if we look at their face, they would like to avoid the obstetric practice. That is the result. And that is not in the interest of the society. The problem is that after the ship is sunk, everyone will know what was to be done. And that situation should not arise. Dr. Chintan has already told about this. So we'll directly go to the cases.
I think you can
This
make
is
it a full screen.
Full screen. Custom slide.
ऐसा पर क्रॉलिंग स्लाइड
Is it seen now?
Yeah.
Yes, sir.
Okay. So 28 years, para 2, previous 2 normal deliveries with regular antenatal care, and this time she required forceps. Suturing was difficult and there was cervical tear on one side. Of course, delivery was fine, placenta expelled out completely, and it was followed by severe PPH. Uterus was well contracted, and perspecular examination showed left angle of the cervix with severe traumatic PPH. Obviously, IV fluids, arrangements for BT, suturing of the stair, but still bleeding continued. Uterus was well contracted, patient went into shock. I asked my esteemed panelists to do now, what would they suggest?
Cervical tear.
Cervical tear was sutured, still patient is in shock. And she
Sir,
is bleeding.
extension of cervical tear.
Yeah, extension
Fine.
of the tear.
But
Leading
how
to
will you know
hematoma.
it?
Broad
How will
ligament
you-
hematoma.
Yeah, agreed, but how will you know it?
Sir, we can go for vaginal examination tenderness, or we can go for ultrasound also.
Yeah,
Bedside
fine.
sonography in the labor room
Fine,
only.
fine.
Yes,
So
sir.
ultrasound was at hand. And there was a large broad ligament hematoma on the left side. You would imagine the size of the hematoma, 15 by 15 centimeter. Uterus was empty. Another 6 to 7 centimeter hematoma behind the bladder, below the uterovesical fold of peritoneum. The reason why I am representing the case so with such a strength, because I have witnessed all these cases. Okay, so now what will you do?
Since the patient is in shock, we'll have to arrange for immediate blood, do her
Okay,
basic
that we have done,
evaluation,
manage.
which is already done.
3 hours were wasted. 3 hours were wasted in shifting the patient to a multi-speciality hospital. And when she went there, she was in shock.
Since the hematoma is large, sir, we will need surgical intervention.
15 centimeter hematoma.
Yes, sir, we require immediate
blood
intervention.
volume.
Yeah.
Adequate
So,
replacement of blood volume.
yeah. We have tried with the replacement, agreed.
And,
but because of the ultrasound late
consent-
diagnosis,
Consent.
that anyway that patient reached to nearby hospital after 3 hours. And she reached there in very serious condition, almost pulseless. Suggestions?
Sir, immediately call for anesthetist, another colleague help, explain, counsel, take proper consent. And
Very good.
it should be like a fast strategy, moving patient, shifting to OT, because we know that patient has already collapsed because vitally compromised. Gathering the
Right.
help and then going for exploratory laparotomy.
Yes,
Taking
yes,
a high
fine.
risk
Very
consent.
good.
Taking high
So
risk
this was the
consent.
culprit. So per speculum examination in every pregnant woman should be done because that caused extension of the tear. There was a bend because of in the last delivery, cervix was inadvertently sutured to the vaginal wall and there was a recess. So that caused a big tear. Fine. Laparotomy was done. As usual, as said, hematoma was drained. Hematoma behind the bladder was also drained. Now what will you do?
So you have to first find out where the bleeding was coming from. If there was colporexis, whether the cervical tear was going all the way up to the bladder or up to the uterus, how far ahead it was going up is what needs to be identified.
So whenever there is a huge broad ligament hematoma, we have got two options. If we see a bleeder, we can catch it. But if we don't see the bleeder because there was a hematoma behind the bladder also, so because there are chances of involvement of the ureter. So interiliac ligation would have been a better option. But patient was in very bad condition. We had no time to dissect, push the bladder. But ultimately, there was no active bleeder from the hematoma. We could drain it. We did hysterectomy, total hysterectomy. So after hysterectomy, we could not see hematoma. So satisfied? Vaibhav?
Yes, satisfied.
So source of bleeding was controlled. Hiral? Everything was done up to the satisfaction, but the problem was on 4th day patient died. So I would like you to give a message, important message in such case.
So first of all, I think during, as you said, first do a speculum examination for all pregnant women at the first visit as far as possible. Secondly, if there was an instrumental delivery or once you have identified that there's a postpartum bleeding, if the cervical tear, what gives us an identification if there's a cervical tear, you can see the angle of the cervical tear. You know that beyond a certain point, there is no tear. Then it's fine to go ahead and suture it from below. Once you can't go beyond the angle of the cervical tear, you consider that there is an extension all the way up higher above the fornix or probably involving the body of the uterus. And that's when an immediate requirement for laparotomy may be needed, is what I feel.
Okay. So before shifting, I think time should not have been wasted.
Sir,
Call for the help. Yeah, Darshan.
Sir, also two aspects, like we are now, I would say, in an era where we are utilizing ultrasound left, right, and center, and probably in these cases utilizing it early, as well as calling for help or for, I would say, blood and blood products earlier. And lastly, in our setup, at least we have a practice that we go for a cross match for every delivery, and that helps many times in such kind
Darshan,
of
but
image.
the next case, the next after the next, we will show you the limitation of the ultrasound. Many times in this case, we could diagnose with the ultrasound, but I will show you one case where ultrasound failed to diagnose.
Sure,
Anyway,
Sir,
another
I would
case.
just like to have 2 comments
Yeah.
on this. Sir, whatever you have, see, whatever the sophisticated instruments and you have, that's good for help. The first and foremost thing what Vaibhav said is correct. See, whenever you are seeing a particular tear or something like that, the angle is very important. So unless you find the angle and you are suturing it beyond it, then only you should be satisfied. Otherwise, you should always be vigilant. The second thing is, like, whenever there is a postpartum hemorrhage, and then you are controlling it with some form of sutures or whatever measures, injections or uterine, you should always be looking at the pulse, because the young patients, if you are controlling the bleeding, the tachycardia should always reduce. So if you notice that the tachycardia is not reducing or pulse rate is continuously increasing, you should always suspect there's something wrong, and you have not done up to the mark. So then you have to be aggressive in thing. The third
Agreed.
thing is, this is the problem with the normal delivery. See, with cesarean, the things you manage it fast. But since whenever there's a normal delivery, and you are always hesitant to do a laparotomy, because you have to go outside and explain the patient's relatives that there is a need for laparotomy. So this hesitation should go. Whenever you find that there is something wrong and the abdomen has to be open, the decision has to be fast. Sometimes because, just being hesitant, you're wasting time, and the vital minutes are gone. And then whatever you do, sometimes you cannot help the patient.
Now, do we have expert?
To add to Dr. Chintan's point, a lot of our deliveries, when they happen, say under epidural, what happens is, if the anesthetist is around during delivery, even with epidural, they are very important people to advise that something has gone wrong, because they are noticing a fluctuation in their pulse volume, they're noticing a fluctuation in their blood pressure status. So if they are around and they tell you that something has gone suddenly wrong, then I think we should suspect something traumatic and take decisions immediately.
Agreed, Vaibhav.
Also, in this case, I want to highlight, sir, that since the uterus was well contracted and still they had sutured the cervical tear, but still patients' vitals were collapsing. So they took 3 hours to diagnose a hematoma. So they should have been hesitant to open immediately, call for help, and go for emergency exploratory laparotomy to check what is going on.
Sheetal. Agreed.
Yes, sir.
Now this case, just go on telling me what was not to be done. What is to be done is not important. What was not to be done? Just go on telling me, even interrupt me at any stage. 2 para, previous 2 cesarean sections. Anybody may interrupt me at any stage. 24 weeks pregnancy, hemoglobin 9.5 gram, O positive, platelets normal, total count okay, USG 24 weeks of pregnancy, anterior placenta on the scar. She has come for the termination of pregnancy.
Not to offer.
Not justified.
Not justified. Okay.
No, won't go for it.
Who can offer? Who can do it? No, I don't think there is any indication. Even we have to refer to the medical board, and I don't think they will also give opinion.
Yes.
Agreed? Okay. So, but still, hysterotomy was done. You go on telling me at every stage what was wrong. Lower segment hysterotomy was done. Previous cesarean section, 2 cesarean with anterior placenta. Somebody reported as anterior placenta, but Agrita was not reported. So do we depend upon our radiologists? I don't think. We should do sonography by ourselves. We should try to find out the exact level where placenta is situated and how to deliver. That also we must remember. So ultimately what was not to be done was done.
Even we can ask for the MRI if we are not sure.
Agreed. So
But keeping in mind that she's previous LSAS and 24 weeks and placenta is already above the scar, we should always think of the Acrita, even if it's not given in sonology or
fine.
MRI. We should be well prepared.
And if somebody is thinking about Acrita, the plan of surgery would be different. But
yeah.
attempt to separate placenta ended up in torrential hemorrhage.
He should not try to separate the placenta. If looking at the obstetric history, if patient's family is completed, then we can go directly for the hysterectomy if patient is willing. Or if family is not completed, we can do one thing.
So
we can separate the bladder as low as possible and then put the incision above the level of the placenta, deliver the baby, keep the placenta in situ, and do the stepwise devascularization, taking the stitches both the side of the uterine upper and lower, then stitch on the cervical isthmus on the middle side. Then if possible, we can separate the placenta. But it is depend on the MRI or sonography report how much millimeter of the placenta is invading the myometrium. If
placenta is already on the scar, Acrita extending into the lower segment, baby should have been delivered by by hysterotomy rather than going through the scar.
Yes.
So call for help, obviously. There was a bleeding, continuous bleeding, and by the time, I don't say I reach, but you just imagine I reach, patient was pulseless, she was in severe shock. Now what will you do?
I am sure when the things which have not to be done have been done, so I'm sure cross match and all was also not collected and sent for because
no cross matching. Initially somebody went for blood and only 2 relatives were there. Counseling was not there. One relative was waiting outside and one had gone for the blood.
Normally what happens is if this happens, the ideal thing is to buy a little bit of time. What we have usually done is try and at least put sponge holders on the uterine vessels to stop the blood from flowing. So what that this gives us a little bit of time or a little bit of bloodless feel, slightly bloodless feel, and allows the pulse pressures to come up. So
anyway, uterus was sutured by the doctor, but lower segment was distended because of the blood collection there. And the bleeding from the suturing side, lower segment was getting torn. Gradually, there were many rents in the torn lower segment. And there was a 8 to 9 centimeter fibroid in the posterior wall of the uterus. Additional.
એક વસ્તુ નવી નાખો છો આમાં.
This is the fact. This is nothing. These are real cases, and these are not even copied from anyone's. These are faced by me, fortunately or unfortunately.
Sir, I wanted to ask is like when such patient comes, how to counsel them that to not to go for MTP like how to continue.
That has been discussed now, but Sheetal, but the thing is, uterus pravi, I did total hysterectomy. We know the legal implications. One PT was barely brought, and then total abdominal hysterectomy was done with a pulseless, BP-less patient. Should I leave from there or should I do hysterectomy?
Legally ke morally?
Anyway, you can speak. Should I go away from there? Because in the MTP case, she will end up in the postmortem. She will end up in a police case. And obviously, relatives are not counseled. So anybody who is going to help will be in trouble. Anyway, health. She came out of anesthesia also. Means suturing was tried for a lot of time and blood loss was severe. And then anesthetists also refused, now we can't give anything. 3 anesthetists, 1 physician and 2 gynec. Helpless. Abdominal closure was just to do it. So still patient in shock and transferred to multi-speciality hospital and transferred to Nirali hospital in gasping state. Now,
Till that patient might went into DIC also. If it will,
that is what I am telling you.
Yeah.
So ICU management, ventilator care, there was a coagulopathy, stabilized. You won't imagine. Total FFP, cryo, and Paxel 72 with blood. And there was a collection in the peritoneal cavity, and all these things were there. And when her INR came to 1.37, still she was bleeding. We opened. Myself and Dr. Vipul Kapadia, both of them, we opened it, got the bleeder, coagulopathy was corrected, and by the grace of God, she survived.
So this case warrants for an award, sir. It's really creditable.
Yeah. So
Now,
I would like to present the things which are...
The important thing is that the take-home point should be that this should have been avoided.
Which are not to be done.
These
things are not to be done. Agreed.
This thing could have been avoided, and means MTP under any circumstances at this point of time should have been not gone ahead with from the very
Or at
beginning.
least case should be given to a tertiary center, should have been opened at tertiary center itself.
Agreed. There are so many things which are to be done, but they were not done, and still she was managed. Anyway,
Just
thank to God.
one more point, sir.
Now we don't see such type of cases nowadays. This figure is also not proper. With this situation, maybe we would hang like this. We won't remain in transverse position. But Dr. Chintan, have you seen such type of after coming here arrested?
A long time,
Yes,
sir.
sir.
I have tried a breech delivery.
Yeah, many years, because nowadays breech, usually we
Yeah,
go
we
for
don't-
cesarean section.
We don't
usually.
offer in a multi-gravida also. So breech vaginal
Agreed.
delivery.
We don't want to take the risk of injury to the baby.
Oh, yeah.
So anyway, suppose such type of case
I
comes
have one
to
breach
you,
pending,
dear
so I'll be
panelists, what would you do? Baby is obviously dead.
I've heard in the
You try
past.
to deliver, assess the
I've heard in the
babies.
past, at least with my father-in-law, needing sometimes having to do even decapitation to deliver the babies.
So, but before decapitation, one more thing was not done, and that was a catheterization. Otherwise, it would have shown blood stain urine. And somebody pulled it, and it ended up in rupture uterus, and you would not believe she died within 20 minutes.
Oh.
Primary near term, she delivered was episiotomy. This is a schematic diagram. Episiotomy extended toward the left iliac spine. Now tell me, what will you do? Vaibhav told me anesthetic is there. Sheetal, Dr. Kaji.
Sir, here,
This diagram is showing there is a tear at the angle.
no, sir, the episiotomy is extended towards the ischial spine. So suturing would be difficult, and we can even take ischial spine. The structures near ischial spine can get injured while suturing the tear if the things are not kept in mind.
So tear was sutured under anesthesia. But after half an hour, they noted that there was a hematoma at the apex. So again, it was opened up, and resuturing was done. Now again, hematoma, and that extended to the paravaginal space. Now, in that case, anesthesia lasted for almost 6 hours. Third attempt was also done. Every
So
time
the
they tried to
subsequent
open the
attempts
hematoma.
were made after calling senior gynecologist or done by the same person.
No, there were 3 gynec.
Sir, can packing help here?
Anybody has done sonography to see the?
No, sonography, do you think sonography will be of any use?
If the
Sir,
image is
The
supra,
problem was there that there was a bleeder,
no,
Sir, can packing
Dr.
help?
Kaji.
yes, sir.
Can packing help?
Is there an
Packing, no.
above the
She
level?
was bleeding like anything. In the end,
Okay.
she required 9 bottles of blood. So I don't think packing would have helped. But what happened? That there was a bleeder that escaped, retracted behind the apex. So if you open it, spurter was coming. So you have to again go up inside, extend the incision, and then catch the bleeder.
Okay.
And then bleeding stopped.
Can we see that once again, sir?
Yeah. So there was a bleeder that retracted above the apex of the tear.
So they have to extend the apex.
Yeah.
Yeah.
I don't say I entered, but I entered and then I opened it more boldly because I could not see the bleeder. So actually it was coming like a spurter. So there is a
Vessel
active
was
bleeder.
retracted.
Yeah.
Sir, as a
So vessel was
principal,
caught and then more
Sir,
difficult was that suturing approximation of both the vaginal walls. Approximation of the vaginal walls.
sir, as a
Very
principal,
widely separated. Very
as a principal, sir, whenever hematoma happens, usually when the bleeding is at the apex, the vessel always tends to retract. So,
agreed. But that
and so
retracted.
if you reopen the episiotomy, sometimes it is retracted, and even then you cannot see the bleeder. So what
So I would
we
like to
generally do is
say that such
what we generally do
explore
is
it properly.
explore it properly. In case you can't, what happens is at least go 3 finger breadths above your apex. Take deep sutures to at least first stop the bleeding if you cannot see the vessel at all. That
Fine.
it might
So-
close, it might stop the spurter or give you some time to explore where the bleeder is coming from.
So another problem was that vaginal walls were torn to such an extent that
That is not
nobody was
possible.
able to approximate. So leave them. Just that undermine on their own margin, leave them.
Correct.
Ultimately, aim was to stop the bleeding. Because you can't approximate vaginal wall. It was very difficult to approximate.
Sometimes the bleeder is supralevator also, the hematoma maybe at the level of the supralevator. So at that time, nothing will happen. You have to open the.
Go for interiliac. Open and interiliac.
So in
Right?
that case, sometimes sonography helps. To see
Yeah, agreed. Another case, delivered normally. After delivery, severe PPH. All resuscitations measures were tried, but still bleeding continued. She went into shock. It was atonic PPH. Emergency obstetric hysterectomy was done. Everyone was reassured that now nothing will happen. Hysterectomy has been done. Now what is the problem? There should not be any problem. Vagina was clean. We were looking for the bleeding per vagina. And while cleaning, there was a small abrasion at 6 o'clock position. Small, very small, which usually we do not notice. And usually it does not require anything except a small pressure with the gauze. But that oozing continued for 7 to 8 minutes. And that she required a stitch. Still that thing was overlooked.
DIC.
After 1 hour, she went into shock.
Yeah.
Now, yeah,
DIC.
agreed. Yeah, agreed. So everybody was present while forcing me to open the abdomen again. What will you do?
So
No, sir, we'll go for blood products and pressure should be
Yeah.
applied to prevent oozing.
That blood products will take time. In a trust hospital, which is away, say about 20 or 30 kilometers, where blood products will not be available to that extent and not up to
Crystalloid.
satisfaction.
first confirm the diagnosis of DIC and manage the shock ask for the blood products.
At least PCV should be given, whole blood, fresh blood.
Platelets 25,000. I did sonography. There was a blood in the hepatorenal pouch.
Okay. So there are two possibilities: frank DIC, or there may be user somewhere at the vault, or somewhere on the stitch line. What
So,
about the abdominal
drain would
scar?
have been kept, no, sir.
What about the abdominal scar? It is clean. It was clean.
Abdominal scar was rather said, dressing was slightly soaked.
Sir, drain output, drain.
Drain was not kept.
Okay.
Ideally, it should have been kept.
Ideally, it should have.
I think I would
Also-
like to keep a drain in obstetric
Also,
hysterectomy now
what happens,
routinely.
one drug which has been known to significantly decrease morbidity in any cases of PPH is tranexamic acid. Usually,
That was given. Everything was tried. That
If-
was given. Even 2 doses were given.
Yeah.
But the thing is, her platelet count was very low.
Yeah.
So that was not a proper thing to open. I don't think that she required to be open. Without, at least INR should be okay. At least platelet should be above 60, 70, 80,000. And fibrinogen we don't get, immediately report. But anyway,
Sir, at
she
this
was
juncture,
admitted.
I just have one question. What investigation would you like to offer when you want to stamp a diagnosis of DIC?
See, I would depend upon first thing on the platelet. In many cases, I have seen platelets are very low. We don't rely upon, even we don't depend, because fibrinogen and FPTT and PT, sometimes it takes time, D-dimer, and even the most important thing is the FDC. But it takes
FDP,
time.
FDPs will take
FDP,
time to.
but it
Sir,
takes
but
time.
what
Sir,
is
FDP, I'll just comment about the FDP or D-dimer. Sir, because in pregnancy, FDP is sometimes
Already
normally
raised.
physiologically raised. So if if you want to be medico-legally safe, okay, FDP, you cannot rely on FDP value to stamp a diagnosis of DIC. Okay, serum fibrinogen, I consider a little bit of value, because if the serum fibrinogen is low, then you can assume that this fibrinogen is being consumed for the consumptive coagulopathy, and then could be.
But
most of the time, the diagnosis of DIC, what I believe is, most of the time the diagnosis of DIC would be clinical. So
But
whenever
you
you
are
are
using these tests in along with the clinical picture that you are suspecting DIC, not just for random people that FDP is raised, but now you are seeing and you are suspecting DIC, and then the FDP values are deranged, then you will consider that there is a possibility of DIC. Also, one very important thing, what we used to do few years back when FDP was not available even for routine patients.
Bedside test is very helpful.
Bedside
Clot
clot
retraction
retraction test. When we used to
Clot
do
retraction
clotting time, we used to keep that tube and
Test
see
tube.
whether the clot has lysed or not. If the clot lysis happens, you know there is a problem. So
But that will
those
also take time.
Yeah, no,
Clot
no.
observation,
Of course,
no.
but it's then it's bedside. If you cannot wait for the blood parameters to arrive.
Anyway, but we have to document the DIC on the basis of not only medically, also with all these reports, because medical legally.
But before we think of DIC, even before we come to the diagnosis of DIC, we should ask for FFP and cryo.
Yes.
The reason is your reports may take some time.
Yeah, should be done.
And by the time your reports are there, initial picture will change.
Yes. I don't think
Picture
there
will
will be
change.
any harm. A lot of people will disagree and say trally happens and this happens, but you are saving it. You are trying to save life. Once you have products available, we should transfuse.
Yeah. Another one. She was admitted with pain in abdomen, previous cesarean section, vertical scar. We do not know where cesarean section was performed. I think somewhere outside Gujarat. 28 weeks pregnancy. Fetal heart's good. On admission, no scar tenderness.
તો 10મા ને
Patient was-
11મું મમ્મી 10મું
હા?
ને 11મું એક દિવસ કહે છે અને 12મું 13મું 18મું ને લીલ પરણાવવાનું.
Hello.
હા તો પૂછી દો મોનિકા.
બધું એક દિવસે શનિવારે કહે છે.
Dr. Monica, please mute yourself. Dr. Monica, please mute
નહીં,
yourself.
આગલા
I
શનિવારે
think this
19
will be the last case. If the time, I think time is okay. Am I with the time or I'm taking longer time? I don't know.
Just summarize the last case, sir. So
Okay, fine.
can
So
go through.
28 weeks pregnancy, fetal heart's good, no scar tenderness, hemoglobin was fine, blood pressure okay, cervix closed. She was under observation, isotropin infusion was started, pain subsided gradually. On the next day again, mild pain, irritable uterus, FHS good, but at night she 10 p.m. Sorry, 10 p.m. There was no pain, no scar tenderness. Then she complained of pain and vomiting at 2 a.m. And before doctor attended, suddenly collapsed.
Silent rupture.
Sudden rupture. Collapse. It's not a dehiscence. Suddenly collapse. Now,
What are the pulse?
Cardiomyopathy.
28 weeks, vertical scar.
Pulse BP findings between 10 p.m. to 2 a.m. Whether tachycardia was gradually increasing, blood pressure is slowly going down. Something is that, or everything was okay.
Relatives said, case paper said that she was sleeping. Will you believe? Nobody will believe it. Anyway, but suddenly she collapsed.
FHS?
Gone.
Okay.
Sir, the uterus. Rupture uterus.
Agreed. But rupture involving a vessel, major vessel. Placenta.
Sir,
Rupture involving the placenta, I think it was a classical section.
maybe, yes, sir.
Yeah, because so the message is any unknown scar, previous cesarean section, don't rely. At least vertical scar, think 10 times.
So a lot of
Well,
things.
I have
mind
evidence.
here. Lot of things come to mind here. This case.
Sometimes
Lot of things come to mind here in this case.
A lot of things come to mind. I appeared in the court for 4 hours, but no protection could help. Anyway.
Sir, I have met with a similar case just for 1 minute. I was managing a case of previous years. She had mild preterm labor and she was approximately 28-30 weeks. Now things were good, just like your case, till evening. Within 1 hour, she had a little more pain, and then FHS suddenly went off. We immediately went for a cesarean section, and we found that it was a scar of classical CS.
Please
It was
continue
done
1 minute.
in Bihar.
Please continue.
Yeah, it was done in Bihar by some general surgeon. Then, in the investigation carried out, some general surgeon had performed it, and it was a vertical scar. So, yes, any unknown scar, it's better to be suspicious about it, the integrity of this scar.
Chintan bhai, two things. One, when this patient gets admitted, if you are suspecting preterm labor, the previous slide said that uterus was relaxed. Now you feel that uterus is relaxed, she is in preterm labor. Usually what we would like to do is check cervical length, check scar thickness, etc. on ultrasound. Everywhere ultrasound is available. There is some time frame that has gone by when the patient has been admitted to when a poor outcome has been achieved. So I would suggest that we measure cervical length, ultrasounds are easily available, scar thickness is available. And if you do determine that there's preterm labor, what is ideally suggested is now no longer to use isoxaprine when etoposide is available. So if etoposide is available, we should be using those instead of using isoxaprine. If you're suspecting a proper preterm labor, is what I would suggest.
Yes, Vaibhav, you're right, but the Atoziban, everybody, it is not in the range of affordability of everybody. One thing. The second thing, how many times would you assess the scar thickness? The second thing, the scar thickness by ultrasound, even the fetal medicine experts, they say that they do not comment on the scar thickness
When
for
you're
the
suspecting,
strength
sir,
of
when
the
you're
scar.
suspecting, when you're suspecting preterm labor.
Yes, preterm. But
May I
Vaibhav,
intervene?
sometimes this preterm labor, when you check for the cervical length, it's not so less that you take a decision that the immediate cesarean section has to be performed.
Correct. So
Because the
sometimes that is what I'm
cervix is.
saying. So when cervical length you feel that it is strong and you find a very papery thing. Let's see, if you were in this patient, if she has ruptured, and if you feel that there could have been a papery thin segment, you know that this is impending rupture.
So the main argument by the litigant in the court was why sonography was not performed. So, is there any argument in favor of doctor that why sonography was not performed?
No.
It has to be performed.
Yes.
So there are RCOG guidelines, which I quoted on behalf of that doctor in the court. I defended that doctor for more than, I think, 4 times, and even last time also a long cross was going on. So RCOG guidelines were actually prepared by, I found out it, and there are certain clear-cut guidelines that there is no cutoff level for the thickness of the scar which can predict that this scar is going to rupture. That is one. Second thing, there is no standard method of measuring the thickness of the scar. Whether you are measuring from mucosa of the bladder to the actually level of the amniotic fluid, whatever it is, but all literature say that there is no standard method to measure the thickness of the scar which can predict the rupture. But our courts and all these things are, 2 courts punish that doctor. Anyway.
Sometimes the
સર તમારા હિસાબે શું કરવું જોઈએ?
હા, see, sonography કરવી જોઈએ, literature કહે કે નહીં કે sonography should have been done.
કરવી જોઈએ ને આપણને એવું લાગે તો પેશન્ટને એટલીસ્ટ એક્સપ્લેન કરવું જોઈએ અને આપણે મોર વિજિલન્ટ રહી શકીએ. If we are
Agreed. I will add you one more thing. Sonography machine did not work that time. હવે મને કહો, જ્યારે બગડવાનું હોય ને ત્યારે everything will be.
સર આમાં ઘણી વખત શું થાય કે we don't have time, આમાં ટાઈમ નહીં હોય ને તમે બરાબર છે, કારણ કે આ તમારી સ્લાઇડમાં ખાલી એ લખ્યું છે કે બીજા દિવસ સુધીની વાર છે, એટલા માટે હું તમને પૂછું છું.
પણ ઘણીવાર scar thickness 6-8 mm હોય ને તો બી આવું થઈ શકે ને. How can we predict that it's 6-8?
That's what Viral I am saying. I have recently a case.
Madam, I feel થઈ તો શકે જ. It is just so that we have taken all adequate steps. That is my
We have to show it. We have to show it that all steps were taken.
Sometimes
documentation should be complete.
Whatever we do, sometimes complications can just not be prevented. But whether or not we have taken adequate steps to try to reach a point where we could avoid it, it has done or not, what I'm saying.
I would just give you an example one case which I had recently come across. Patient was having 28-30 weeks pregnancy. She was not having symptoms and all that. During the growth scan, the renowned radiologist had reported the scar thickness less than 2 mm. The gynecologist ordered or advised immediate LSCS. She was completely okay. She came to me for a second opinion, and we could prolong the pregnancy for 4 to 5 weeks more till the baby went up to the 36 weeks and 2.25 kg. And mine was, I was having a dissertation topic of, VBAC in previous cesarean section. we had a good amount of study of, this sonographic assessment of scar thickness. But ultimately, we find that, the sonographic assessment of scar thickness has a lot of subjective variation, and it is not having a good predictive value as far as the impending rupture is concerned.
Agreed, Chintan Bhai.
So,
I presented.
whenever we are doing a sonography for scar thickness, we should be clear in mind that at what cutoff point we are going to offer her a cesarean section immediately without waiting for
So
any
there
form of
is a
treatment.
large margin between 2.2 millimeter to 0.6 millimeter, which they have given. But the thing is that even though I argued like all these things in the court, and even judge has written that sonography thickness means કે ગર્ભાશયના કાપાની જાડાઈ સોનોગ્રાફી દ્વારા માપવામાં આવે તો તે જાડાઈ આપણને આ સ્કાર રપ્ચર થઈ શકે કે નહીં તે નક્કી કરવામાં મદદરૂપ થઈ શકે નહીં. એગ્રીડ. બટ ધ એગ્રીમેન્ટ આર્ગ્યુમેન્ટ વોઝ ધેટ કે એમ થાય કે ના થાય, પણ એ કર્યું હોય તો શું ખોટું? Average doctor would have done it. And they passed the remark that this looks like a clear-cut case of negligence, but still why this witness? He says that there is no negligence for the reasons known to him. Anyway, any comment kariye te kare. But whatever the literature is different and whatever the things are, any doctor would have done sonography. He has not done that, means there is a problem. So we'll proceed to the next case.
નહીં સર, આમાં બીજું સોનોગ્રાફીનો ફાયદો એ થતે કે આપણને વોટ ઇઝ ધ વેટ ઓફ ધ બેબી કદાચ ઇમિડિયેટ કાઢવું પડતે કે નહીં, give us time for betamethasone, Magsalv, etc. All those things. The fetal well-being is also a very important part of ultrasound. So in
Sonography, yes, that is agreed.
In case a uterine rupture, forget rupture, so we cannot prevent if it's going
Apart
to
from scar
happen.
thickness, there are many things
But
that sonography would able to
But the
help
other
you
thing
out.
is that if we
One more
wanted
thing.
to go intervene for the baby delivery, we could have done so.
One more thing. Suppose machine is not working. What is our legal protection? In a case of Jacob Matthews versus State of Punjab, Supreme Court has clearly said that failure of machinery or infrastructure is not a negligence of the doctor. So he should have written on the case paper that unfortunately sonography machine did not work. I've tried for that. So this should be done.
સર આપણને સેફ રહેવાની જગ્યા બતાવે છે.
Hiral. So again, 2.9 kg regular antenatal care, cervical dilatation, early labor, and she delivered within 1 hour and 40 minutes.
Precipitated liver.
Whatever you can call. Active management of third stage. There was no cervical tear. Was under observation. So after 12, the majority of the obstetric mischiefs or mishaps that occurs between 12 midnight to 4:30. That is a very dangerous time. I think everybody will agree.
Agreed.
Dr. Kaji.
Agreed, sir. 12 to 4.
Our staff is sleeping. Everybody is blazing. A patient relatives are also, they are gone. Some of them are there, some are not there. So after 12 hours in the morning, she felt weakness, fainting, pallor, pulse, tachycardia, blood pressure. Hemoglobin fell from 11 to 6.5 gram. Uterus well contracted. Now, what will you advise?
Sir, there is somewhere bleeding, but first we'll go for even per vaginal examination. We should.
There is no vaginal bleeding.
Sonography.
Hematoma.
Yes, agreed. Sonography was done. And you will be surprised to see that 2 sonologists, they did not report rupture uterus.
Okay.
That is the thing that what I would like to convey, that don't depend upon the sonologist every time. The reason is they might be reporting anything, but clinical picture matters always. If you think that she is bleeding inside, you are justified in opening. Yes. CT scan was requested. And on CT, there was a hematoma in the broad ligament. Now,
સર આ તો પહેલા કેસ જેવું જ થયું ને broad ligament એટલે we have to order
I
BT
agree, but this is
anesthesia.
different. That was evident. This is not evident in ultrasound. CT diagnosed it. So even if we are suspecting that she is bleeding somewhere, hemoglobin fall from 11 to 6.5 is something serious.
Suspicious.
That is one thing. Pallor is also something serious. Tachycardia increasing is also, as Dr. Kaji has also said. Tachycardia, I don't like tachycardia. Tachycardia in obstetric patient is really something, warning sign. And then when patient gets some, sometimes they become giddy. So these are not good signs. Anyway, ultrasonography, CT were done. And ultimately diagnosis was late. Anyway, so I think we have gone beyond 1 hour. Any comments from the panelists?
સર
One
કેસીસ એવા હતા ને કે જે અમે મેડિકલ કોલેજમાં જોયા હતા અને ઓલમોસ્ટ કેટલું બધું એવું હતું કે આપણે આવી જ શકે છે. We should be vigilant for each and everything. This can happen with anyone.
Try to get proper history.
Documentation.
Sometimes, because I have seen one patient, previous cesarean section, rupture uterus, but rupture from fundal, not from the scar. And the history was myomectomy has been done when patient was unmarried.
સર બીજું એક વસ્તુ એ જોયું કે કોઈ બી મોર્બિડિટી કે મોર્ટાલિટીનો કેસ હોય ને આપણે તો ચેક કરવાનો આપણા જે ન્યુટ્રલ કલીગ જોડે ચેક કરાવવાનો કે આપણું ડોક્યુમેન્ટેશન બરાબર છે કે નહીં. કશું આપણે મિસ તો નથી કરતા ને સિનિયર પાસે.
Vaibhav, will you comment something on this?
અને consent બરાબર લેવાની સર.
Documentation and preparing the record?
Documentation, preparing the
Immediately.
record. I think is
Immediately, within 12 hours.
Within 12 hours, I think I should be done as early as possible.
ના સર પણ પછી બી આપણે બેસીને કેસ તો કમ્પ્લીટ કરવો પડે ને.
હા, કેસ તો complete કરો, but it is in a designated time frame. We cannot take endless amount of time.
Exactly.
Two new developments have occurred. Whenever there is any problem, crowd will be there, mob will be there, and they will ask for the case paper.
Yes.
They will try to snatch away the case paper. They will try to take the photographs of the case papers. That is one. And second thing, this really with the board and everything, and they will go to the collector. So give me your suggestions. Vaibhav.
We are not liable.
Dr. Kaji.
We are not liable to give the case paper to the mob or to the relatives when there is a mortality.
સર કલીગ્સ ને હેલ્પ માટે બોલાવવા જોઈએ.
Agreed.
First thing.
એટલે gray hair, do you think gray hair makes difference?
Very much.
Okay, fine. Then
સર
give
અમારે તો
suggestions.
108 ગજ્જર સર અમારે તો 108 જ આજે મોડરેટરમાં છે. અમારા ભરૂચનું 108 જે કહીએ ને અમે ચિંતનભાઈ. અમારો પર્સનલ 108 છે.
બરાબર. હવે suppose they ask for the case papers and you don't give them, then call police. That is one. Let us call police. That is one. Second thing, still they will ask for the case papers. Should we give?
No.
પણ સર હું તો કહું એ લોકો પોલીસને બોલાવે, આપણે આપણા સેલ્ફ એ માટે આપણે જ પોલીસને બોલાવી લેવું જોઈએ.
See, agreed. We should call police. Calling up police is one thing, and giving the case paper to them is different thing. If you don't give them case paper, they will be aggressive, and something which is not expected may occur. So give them case paper with some note on that these case papers are handed over to relatives by forceful demand. They are to be prepared, yet to be prepared, and we need a time to prepare. MCI has given 48 hours. Next day problem occurs that police will come for the case paper immediately. Next day maternal mortality people will come for the case papers.
સાહેબ everybody actually અમારે ભરૂચમાં મેં જોયું છે everybody gives you a time. એટલે એવું નથી કે આમ within 24 hours જ લોકો આવીને બેસી જાય છે એવું નથી. See, relatives ને handle કરવા whenever you are in trouble and whenever there is some mishap, relatives ને handle કરવા is always a tricky situation. But as far as this maternal mortality, Zilla Panchayat and everything is concerned, they always give you some time, give doctors some time to make the case paper ready, because see even court understands કે તમે emergency situation હોય ત્યારે you are not તમારી પાસે finding લખવાનો ને એ બધું case paper complete કરવાનો time કે એવું ના હોય એટલે
Agreed.
you always
You
need
can
some
request
time.
even police also. You can request
હા.
even these maternity people also. No problem.
કારણ
We
કે
are
રિલેટિવ
authorized
નું
to give
એગ્રેશન તો
things.
સાહેબ તમે કેસ પેપર આપશો પછી એ રહેવાનું જ છે એટલે whenever they are not agreeing that there is no mistake, so you have to handle them in a tricky way, but at least you should get some time. You should
There are some people or some doctors, I can say, like some are very good handling the emergency in the operation theater, and some are very good handling this type of mobs. So we must know type of our senior colleagues that who can handle that mob very well, because as a
in Bharuch we are having one team. We are calling it immediate squad. We call one person and he keeps on gathering the other
it's a
person.
rapid action team.
Rapid action team.
we are also having the same team.
Vibhav, what do you say about Navsari? Your president NOGS.
Sir, we gather a team, but sometimes it's difficult to handle the mob because the mob numbers far outweigh the doctors available also.
Our
So-
staff should know the numbers of our colleagues. Police and our colleagues should be informed simultaneously if we are finding that mobs is aggressive.
અને સર અમુક વાર એવું જોવાયું છે કે એ જે ડોક્ટર જે હશે ને તેનું કોઈ નહીં સાંભળે, but if some new other gynecologist will come, they will be easily convinced by the gynecologist which is not attending the case but who are there other than the gynecologist attending the case. એ સારી રીતે સમજાઈ શકશે મોપને. That is what I have seen.
Anyway, with the help of the police, we should tackle that 2-3 hours initial. Then we can prepare the case papers, but case papers should be prepared with the help and the guidance of some senior or a medical legal consultant before we hand over case paper to anyone.
Our documentation is એ જ આપણો હથિયાર છે, એ ગમે તેને આપી ના દેવાય. કારણ કે ફ્યુચરમાં જો આપણે પ્રોબ્લેમ થશે, તમે શું કર્યું એ કોઈ નહીં જોવે, તમે શું ડોક્યુમેન્ટ કર્યું એ જ જોશે.
So once we hand over documents to maternity people or to police or relatives, then we don't have that much defense left.
Yes.
Because of the lapses in the case papers. Anyway, such type of situation is worsening. Second thing, rally culture. They will come out from the house or hospital and go to the collector. I think police will not give permission for the rally. And you should insist police also not to give permission. And police will not give permission. They will not go for the rally. This has to be done by us. Otherwise, if we don't do this, then doctor will have a loss of reputation. Let
But
them
sir,
collect to the...
What do you say about social media abuse other than rally?
Nonsense. No, nothing. Forget about them. They may write anything, no problem. Nothing. The people will forget day by day. So many stories are coming. Nobody will read it. Everybody know. Those who are coming to your place will come. Those who are not going to come will not come. Forget about it. I don't think it will affect our practice in the long run.
Compared when it comes to social media, sooner or later regulations will come where you will not be able to damage someone's reputation, etc., without having official proof. અત્યારે શું છે, social media is being blown, like it's going crazy everywhere. પણ ઓવર ટાઈમ એનું બી રેગ્યુલેશન થશે કે ગમે તેને ગમે તે તમે બોલો, કંઈ બી કરો, વિધાઉટ યુ બિંગ હેલ્ડ રિસ્પોન્સિબલ એ નહીં થશે. એટલે કદાચ કોઈ તમને કંઈ તમારા માટે ખોટું લખી બી દે કે બોલી બી દે, but that if that happens and it has caused you harm, you might, and once you're proven that you're not guilty, you might be able to fight it out for defamation or whatever. I don't know શું હોય legal procedures. I'm not in the best. Dr. Patel will be able to help us.
ઇવન તમે ગૂગલ રિવ્યુઝ જુઓ ને તો બી અભણ માણસ તમારી સ્કિલ ને તમારે શું કરવું જોઈતું હતું ને કેવી રીતે તમે ખોટું કર્યું એના વિશે તમને આખો પાનું ભરીને રિવ્યુ આપશે.
એ તો રિવ્યુ ખરાબ હોય તો જ લખે રિવ્યુ. सारे तो फिर कौन
Sometimes what happens that a patient who has died at another doctor's place, that patient's relative will go to the another doctor's place, and they will say that all doctors are like that. Let us punish them. This thing also happens. They make the group, but this thing does not last longer. People will forget it. Daily such things are coming and going. We do not worry about it. We need not answer them. If you answer, they will continue it for many days. Anyway, with your permission, Dr. MC Patel is there.
I am very much here.
So,
nicely
Thank you.
conducted panel. So I would say big round of applause for two learned moderators and all the learned panelists making this panel very interesting. Because these
Thank
are
you,
the
sir, for the
very
opportunity.
common cases we face in our day-to-day obstetric practice. So how to deal with and what not to do is equally important. What to do is of course important, but what not to do is also equally important. And that way it was nice discussion.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Thank you
So,
all. Thank you, Dr. MC
Monica,
Patel, Vaibhav,
Thank you.
Sheetal,
Thank you,
Viral,
everyone.
Chintan Bhai,
yes, we can conclude with
Monica.
what of things.
Yes. I would sincerely like to thank Dr. Atul Munshi, sir, for joining us as the chief guest today, as well as Dr. Dwivedi, sir, Dr. Hemant Bhatt, sir, for being the guest of honor. I also like to thank all the three faculties who have had excellent discussions and on very important topics like the birth injuries. The panel discussion was the icing on the cake. It had very, very important topics of discussion and a very good take-home message. All concluding to the remarks that most of the times documentation is the key to and the savior in the court of law. And as rightly said by Patel sir, do everything what you can do in the good faith of the patient and document it, which is very, very important. Also like to thank Corona Remedies for the academic grant and wishing you, sir, all the very best for all the future endeavors in Foxy. And I'm sure everybody of us will take an extra effort from our side to see your dream come true. Thank you, everyone, and good night.
And one more thing on my behalf, as a Secretary Sogog and on behalf of Chintan Thakkar, President Sogog, I invite you all for Sogog conference, which is going to be held at Ahmedabad on 19th, 20th, and 21st December. So please register yourself in that very conference, and we are eager to welcome you at Ahmedabad for all the warm welcome and good hospitality. Thank you very much.
Thank you, sir.
Yes.
Thank you all.
Yes. We can conclude.
Okay, fine.
Thank you, sir. Thank you, judges,
yes.
sir, and thank you all all star panelists, and thank you all faculties for making this program a fantastic one. Really enjoyed.
So next Tuesday we are going to discuss labor room emergencies, and it is with some more other 5 societies of Sogog, Bhavnagar, Vadodara, Anand, Nadiad, Godhra. So you are most welcome to join that
Thank you,
webinar
sir. Yeah, we'll
next
definitely join.
Tuesday, 6 p.m. Thank you very much. Yes, Corona, Nilesh, we can conclude.
Okay, sir. So thank you so much, all the respected faculty members and delegates who are present over here. It was a wonderful webinar from Corona Remedies. I thanks Dr. MC Patel, sir, for giving us this opportunity. And we hope we will continue to support you like this. And with this, we are concluding this session. Thank you so much again, everyone. Thank you. Thank you.